Good morning, everyone. It is wonderful to be with you. I'm sorry that it has to be in a remote fashion rather than in person, but those are the days we're currently living in. But my topic, which I hope is somewhat unique to what we're going to discuss, is how opioid use impacts esophageal symptoms and motility. What we do know is that opioids are being overly prescribed and overly used. In the upper gut, these medications do cause symptoms. We are familiar with some of those. I will not be discussing some of the lower GI symptoms that we are comfortable with. However, I will discuss how they impact specifically the esophagus and esophageal motility, because these are patients that we will often see, and to know what the impact is and what to do for this group of patients is very important. I have no disclosures relevant to this presentation. So as I mentioned, opioid prescription has increased over the years. We know that in the year 2000, there were about 164 million, while just in 2010, it had increased to 234 million. And as you can imagine, today, those numbers are going to be much higher. And as you have seen in the media, it is the worst drug epidemic in the US history. We're seeing this at various levels. We know that 130 Americans a day die every day from an opioid overdose. This can be either prescription or illicit use of the opioids. We also know that 4% of US population use opioids for non-cancer related chronic pain. There's no judgment on whether or not patients should take opioids. The issue is we do know that it is overly prescribed and overly used that leads to a national crisis. So my focus is going to be on the esophagus. However, we do know that opioids impact the GI tract as a whole. We know that opioids impact the colon. It slows down colonic motility. It leads to constipation. This is something we're familiar with. We also know that opioids impact the stomach. We know that it slows down gastric motility. Many of our patients have nausea, vomiting because of this. So in the stomach, it actually impacts the pylorus as well. In addition to slowing down the stomach, it actually impacts the pylorus by increasing the pressure. So it makes it worse. You can't empty, and the pylorus is actually hypertonic. In the small intestine, it slows down the propagation, but it also increases the contraction, i.e. reduces the peristalsis. So again, overall, the impact of opioids in the GI tract is large. However, in the esophagus, there's some unique findings. And the aim of this discussion is to really talk about that. I'm not going to talk about gastroesophageal reflux disease per se. However, some of the patients that might present to you may have reflux. If the opioids impact the small bowel and or the colon or the stomach, then what you might see is someone that has refractory symptoms. They may have heartburn. They may have regurgitation from gastroparesis due to opioids. It may be that the constipation is leading to more upper GI symptoms, and we're seeing more and more of that. But in the esophagus, I'd like to focus on what opioids do regarding esophageal motility, because this leads to certain symptoms such as dysphagia, and then we end up doing endoscopy or esophageal motility testing, and there are some specific motility pattern related to opioids and the esophagus. So I'm going to walk you through this slide. I will not be talking about the endogenous opioid peptides that impact the opioid receptors. We are talking about the exogenous opioids, which are structurally distinct. Now, these opioids impact the mu receptors predominantly in the GI tract. Now, these receptors are predominantly in the myenteric plexus, and they are G protein coupled membrane receptors. What the impact of this interaction is reduction in the cyclic AMP and the impact on calcium channel and increased potassium permeability. What this does, which is the impact I'm going to discuss, is inhibition of neuronal activity and neurotransmitter release. This leads to some esophageal dysmotility. It leads to some symptoms, and I will discuss that. Now, I already mentioned that this function leads to abnormalities in the esophagus. Like I mentioned, there's gastroparesis and hypertonic pylorus in the stomach and reduced peristalsis, as well as hypertonic contractions in the duodenum. So let's focus on the esophagus. And what I urge the group, if you're really interested in this area, to look up this article in the American Journal of Gastroenterology that was published in 2019 by Dr. Patel, who's really done a great job of highlighting the impact of opioids on each of these areas, esophagus, stomach, and duodenum. And I'll be referencing some of the work of Dr. Patel in this as well. So this slide, again, taken from that article, shows how opioids impact esophageal motility. In a patient that might present with dysphagia, and many of these patients do, what we see is perhaps jackhammer esophagus. Well, we will see this hypertonic contraction as you see here. Patients might have distal esophageal spasm, as shown in this clip, or be diagnosed with type 3 achalasia, as shown here, or this condition called EGJ outflow obstruction, where essentially what we have is the GE junction is not relaxing, although there is peristalsis. And this is somewhat nonspecific, but we do see this in patients that have been on chronic opioid use. So how do opioids impact the peristalsis in the esophagus? Before we talk about the opioid impact, we need to know what normal peristalsis is. We do know that esophagus contracts and relaxes. It is the combination of the contraction and relaxation, and the relaxation occurring at the end of the bolus, with the contraction occurring more proximally, is what really causes the peristalsis in the esophagus. This is driven by presynaptic and postsynaptic terminals and how these neurotransmitters, acetylcholine resulting in contraction, while nitrous oxide and VIP resulting in relaxation. That's a normal function. However, in someone that may have been on chronic opioid use, what you see is continued contraction, but nitrous oxide VIP fibers in the myenteric plexus are impacted. And as I mentioned, through this, you have continued contractions, and the latency gradient between the esophageal segments are reduced, which means there is lack of peristalsis, and there's increased contraction, which is why what you might see is a picture that is a hypercontractile state, as I've shown in the previous slide. Looking at this study that was published in the American Journal of Gastroenterology in 2015, they studied patients on opioids and off opioids. And clearly what they found was that EGJ outflow obstruction was significantly more in those that were studied on opioids versus not. Same with achalasia type 3. And this is a pattern you're going to see in different studies that I'm going to present to you. Now, what we do know is from this study, again, looking at it pictorially, in someone that's on chronic opioid use, we see this EGJ outflow obstruction pattern. There is hypercontractile state. Someone could have typical type 2 achalasia. As you see here, there's lack of relaxation of the EGJ. As well, you have simultaneous contraction. You may have type 3, where the LES is not relaxing, and you have very high amplitude contractions, or jackhammer esophagus, again, shown here. These are patterns that have been published in the literature on patients that have been on chronic opioid use. This is a study that I'm going to present a few slides on. Dr. Babai published last year, 2019, on a large group of patients, as you can see here, more than 2,000 patients that he looked at, and he divided that population to those that were opioid naive versus those that were on chronic use of opioids. And what he found was that dysphagia was the predominant symptom presenting that differentiated the two. Patients on opioids are more likely to present with symptom of dysphagia than those that not. And this results in performing endoscopy if patients present to gastroenterologists, as well as potentially esophageal motility testing. So when a patient comes with dysphagia, and if endoscopy is normal, which in most of these cases it will be, then they undergo esophageal manometry. High-resolution manometry, as shown in this slide, shows that patients on chronic opioid use are more likely to be diagnosed with achalasia type 3, as I've shown, EGJ outflow obstruction, or esophageal spasm. This is a study by Dr. Patel, who was the author of that review that I was mentioning earlier, where he looked at his patients that he's seen at Vanderbilt, in fact, and his sample size was much larger, more than 5,000 patients. He similarly divided the 5,000 patients to opioid naive versus chronic opioid exposure, as you can see. And what he did find was that, again, patients on chronic opioids are more likely to have jackhammer esophagus or distal esophageal spasm. However, he did not confirm that type 3 or type 2 were more common in patients on chronic opioids than in opioid naive. However, the main point being that they do present with dysphagia, and hypercontractile state is very common in this group. And what he did find was that patients that are on chronic opioid are more likely to have distal contractile integral, or DCI. This is a measure of the strength or the vigor of contraction. You notice it is significantly more. The mean esophageal amplitude was also more. The basal LES pressure was higher, and the integrated relaxation pressure was higher. So what that means is that those on chronic opioids are more likely to have a stronger vigor on contraction, and the LES is less likely to relax completely, which then leads to the symptom of dysphagia that we've been talking about. In that same study, Dr. Babai looked at different diagnoses: achalasia type 3, EGJ outflow obstruction, spasm, or others, and he showed that the morphine equivalent dose, if you look at that, the higher the morphine equivalent dose, the more likely to be in the hypercontractile state, either type 3, EGJ outflow, or spasm. So again, the longer and the higher the dose of opioids, the more likely we might see this. This is a new recognition of this condition, in that previously patients would present to us in the manometry lab. We would do the manometry, but there would be less focus on whether patients are on chronic opioid use. But now we're highly focused on that, because we are recognizing that this is an exogenous factor leading to similar diagnosis, for example, as idiopathic achalasia. That's important because perhaps our treatment would be different in the two conditions. So, are there specific opioids that may be more causal than others? And the answer to that is, at least based on the studies that have been published, is that patients on oxycodone and hydrocodone tend to have more issues with the motility findings that I've been highlighting, rather than those on the partial agonists, such as tramadol or codeine. So patients on tramadol and codeine don't have the same association or the same impact as those on oxycodone or hydrocodone. So that's important to know. This is important because if patients are on those medications, perhaps one treatment option would be to go to partial agonist to reduce that association and perhaps help the patient's symptom and the motility findings. So we've been discussing the clinical presentations. How do these patients present? Obviously, they're on opioids chronically for various conditions. and patients will often present with dysphagia to solids and or solids and liquids. They might have regurgitation. Remember, the regurgitation can be esophageal in etiology because of esophageal motility disorder, or it could be gastric because of gastroparesis. And obviously they could have chest pain because of increased vigor of contraction. However, clinical symptoms alone don't differentiate where the problem might be, because a patient with dysphagia could have reflux-related strictures. So we're still obliged by performing endoscopy, making sure there are no other etiologies for the dysphagia and or regurgitation. So symptoms alone don't tell you just because someone is on opioids. So this is a patient, endoscopic picture of a patient that we performed. You see some retained saliva, puckered GE junction. This is classic for achalasia. However, this patient had dysphagia to solids and liquids, had this endoscopic finding, but this is not idiopathic achalasia as we know it. This is opioid induced. This patient was on chronic opioid, and when we actually transitioned the patient to partial agonist, the symptoms did improve, as did the motility findings. That's hard to do in many of these patients. However, this endoscopy picture, the aim of it is to show you that endoscopically and symptom-wise, it could be very similar to idiopathic achalasia, as I've already shown you some of the manometric findings associated with the opioid-induced esophageal dysmotility. This is a study, a different study by Dr. Babai, in that what he found was, what if we wanted to know, is this really achalasia, idiopathic, or is it opioid-induced? So this is idiopathic achalasia type 3 and opioid-induced. Are there provocative maneuvers we can do in order to differentiate? And what he did was he used amyl nitrate inhalation. And what he showed was that in idiopathic achalasia with amyl nitrate, there's relaxation. As you can see, the LES relaxes, but then there's a rebound contraction in idiopathic achalasia that you don't see with opioid-induced achalasia. Again, that's if you wanted to differentiate. Same thing with CCK. CCK typically results in relaxation in normal subjects of the smooth muscle. However, in patients with achalasia, it actually has the reverse effect, because what it does is it increases contraction. And as you can see with CCK injection, you have heightened contractions, which is typical in idiopathic. But what he found was that in opioid-induced, that rebound or contraction is really not as strong. So if one wanted to know whether this was really truly impact of idiopathic versus opioid, one could use some of these provocative maneuvers to differentiate. So what do? You do a thorough medical reconciliation, obviously, and can you do the manometry of opioids? Now, that's easier said than done, obviously. Many of our patients on chronic opioids, it's going to be exceedingly difficult to, by yourself as a gastroenterologist or primary physician, to really take them off opioids. So this has to be in concert with your colleagues in pain, if they are seeing someone in a pain clinic, in order to coordinate whether you can go to partial agonist and whether that will help the patient. But now you're left with a patient that has dysphagia and you're suspecting it's opioid. Chronically, the best would be to try to get them off and or into partial agonist. Acutely, you're left with what we typically do, however, which is likely endoscopy, and I'll highlight some of the treatment options that way. And this essentially highlights what happens if you are able to take them to either partial agonists or get them off the opioids. You see on the left, the hypercontractile state. On the right, this is the same patient that essentially was off the opioids. So management, what do we do? Well, there's lack of data on using opioid antagonists. We know that there have been trials on opioid antagonists in the colon regarding constipation that may be opioid related. However, we don't really have data on its impact in the esophageal patients that have this motility. So obviously we talked about withdrawal of opioids if safe and if doable in concert with a multidisciplinary approach. If not an option, switching to partial agonists, as we said, tramadol perhaps, and empiric esophageal dilation, because that's more of an acute setting in that you're left with a patient that continues to have dysphagia. If it's a spasm, if it's EGJ outflow obstruction, you should do an esophageal dilation empirically. The question could be, what do I do? Which specific dilator do I use? And we can discuss that in the Q&A part of the presentation. There's also a role of botulinum toxin. As you know, botulinum toxin we have used in patients with achalasia, specifically idiopathic. It is also being used in patients with hypercontractile states, the idiopathic spasms and others. And this could be helpful if dilation alone was not sufficient. So what I tend to do is first dilate the patient, and if that's not enough, I bring the patient back and do some botulinum toxin injection, depending on the manometric finding. If the manometric finding shows more of a spasm, then I inject the Botox along the esophagus, and if it's more EGJ outflow obstruction, then I inject into the lower esophageal sphincter, as this pictorial shows. So what is the method? I use 100 units of Botox. I usually inject 25 units into each quadrant of the LES if I'm injecting it for type 3 and or EGJ outflow obstruction. However, as I mentioned, I would potentially use about 10 units along the esophagus, 4 units, 40 units into LES, and then the rest along the esophagus if spasm. And the way botulinum toxin works is it blocks the acetylcholine release. And remember, the hypercontractile state, as the first few slides I showed you, is because of the contraction that's due to acetylcholine, and botulinum toxin essentially blocks that. So what are some risks? Sometimes patients have transient chest pain post injection. Some patients get reflux symptoms. I haven't had that many. There's been one death from mediastinitis, but again, very rare. So what do you do for refractory symptoms? So you tried that, you did the empiric dilation, you did the Botox, patient continues to have it, you were unable to take the patient off of their opioids or convert them to partial agonists. So you're then left with essentially, you could do the time barium to see if there's retention of barium, just like you do with idiopathic achalasia. You could consider pneumatic dilation or myotomy, but I would be highly cautious in this group, especially if pain is what's driving what you're doing. If patient's pain is exceeding more the dysphagia, you want to know that pain is less likely to go away. Dysphagia would be more likely to be treated with the measures that I've outlined in this presentation. So this is my last slide, again, highlighting the fact that we are in a crisis situation, in that we do have many of our patients that are on opioids, and there has been such increased attention to esophageal motility, as well as some of our refractory patients with reflux. I didn't discuss that, but we have many patients that while on PPIs, their reflux symptoms not well controlled, and that could be due to the impact of opioids as well, whether it be the impact on the stomach or duodenum or colon, or the factors that I mentioned in this presentation on esophageal motility, such as jackhammer esophagus, distal esophageal spasm, type 3 achalasia, or EGJ outflow obstruction. And I'm more than happy to answer questions in the Q&A part of the presentation. Thank you.
My name is Ronnie Fass. I'm a professor of medicine at Case Western Reserve University, and my topic is GERD and sleep and eye-opening experience. These are my disclosures. First of all, let's talk a little bit about sleep. So sleep is now considered one of the 3 pillars of health. We're very well aware that exercise is an important pillars of health. In addition, nutrition has been considered to be an important pillars of health. And then recent information and data and evidence suggested it's also sleep. So for having a healthy life, one has to focus on all three components, and not only on two of them or one of them. Now, it's very interesting that when you look at this study from 1960 to 2002, so over 40 years period of time, we lost on an average 2 hours from our sleep. In fact, when we look today, we'll find out that most of the adult population sleep on an average no more than 5 to 6 hours per night, suggesting that a significant part of our population falls under the category of being sleep deprived. Now, many of you probably know that regular naps prevent old age, especially if you take them while driving. Now, what are the health consequences of sleep deprivation? So sleep deprivation doesn't come cheap. There are many studies showing that patients that are sleep deprived are more likely to develop accidents, either motor vehicle accidents, accidents at work, or even accidents at home. But there's also information that sleep deprivation is directly associated with obesity, dementia, memory impairment, heart disease, and even reduced immune response. So sleep deprivation is a very important abnormality that has to be addressed. And obviously, we have to find out what the underlying mechanisms that can lead to sleep deprivation in our patient population. Now let's look at the effect of sleep on esophageal function. And it's very important because you can see how sleep can affect esophageal response to gastroesophageal reflux. Now during sleep, there is significant decrease in swallowing. In fact, almost to none. There is also significant decrease in salivary secretion. Now, these are two important defense mechanisms against gastroesophageal reflux. Swallowing results in primary peristalsis that delivers saliva to the lower part of the esophagus. And saliva can neutralize the presence of acidic reflux. In addition, during sleep, especially deep sleep, there is a decrease in upper esophageal sphincter vasopressure, potentially allowing for reflux traversing the upper esophageal sphincter, ending up in the larynx, pharynx, and pulmonary system. During sleep, there is also loss of gravitational effect. Sleep is also a state of, sleep is also a state of altered consciousness. And as a result, there is decreased perception of intraesophageal stimuli. That means we sense less inside our esophagus, and consequently, we're less likely to perceive events in the esophagus and respond to them. During sleep, there is also decrease in primary peristalsis. As I mentioned, primary peristalsis is very important in delivering saliva to the lower part of the esophagus. And as a result, that can increase acid exposure time. There's also evidence that during sleep, there is a component of decrease in gastric emptying. And if you sleep on the right side, you are more likely to experience reflux disease because of the anatomic relationship between the esophagus and the stomach, as compared if you sleep in any other position. So you can see how sleep physiology can be affected. Now, nighttime reflux increases risk for GERD complications. In fact, reflux during nighttime has been shown to be the most malignant, literally malignant type of reflux. So patients that have nighttime reflux are more likely to develop erosive esophagitis. They're more likely to develop complicated gastroesophageal reflux disease, having ulceration, strictures, Barrett's esophagus, or even adenocarcinoma of the esophagus, as compared to those that don't have nighttime reflux. In addition, patients that have nighttime reflux are more likely to develop extraesophageal manifestations of GERD. They're more likely to develop asthma, aspiration pneumonia, chronic cough, hoarseness, and many others. But also, they're more likely to develop sleep abnormalities that lead to sleep deprivation. And as I've already mentioned, the initial of my presentation, sleep deprivation has many other health-related consequences. So how common is heartburn that awakens patients from sleep? Well, it's very common, as you can see from 3 different studies, showing that between 47 to 54% of the GERD patients reported having heartburn that awakened them from sleep during the night. That's almost half of the GERD patients, suggesting that this is a very common phenomenon. In addition, patients that experienced nighttime heartburn also reported a variety of sleep effects. 63% of them said that nighttime heartburn affected their ability to sleep well. 42% said that they were unable to sleep through a full night. 39% of them said that they had to take naps during the day. And 34% of them stated that they had to sleep in a seated position. So a significant effect on patients' quality of life. Interestingly, 27% of the patients reported that their own heartburn-induced sleep disturbances kept their spouses from having good night's sleep. So sleep disturbances may affect also your bed partner. There are also studies like this very important survey that was conducted by the American Gastrological Association. They looked at more than 1,000 GERD patients, and they wanted to see how many of them still have breakthrough symptoms despite taking PPI once a day. And they found out it was more than a third of these patients. And when they asked them, when do you have those breakthrough symptoms, 65% of them said at night, and 28% of them said during sleep. So nighttime, sleep time were associated with a higher rate of breakthrough symptoms in patients that are already taking anti-reflux medications. And this is a study that we've done, and we wanted to look at the association between nighttime gastroesophageal reflux disease and a variety of sleep abnormalities. And we found out that patients that report nighttime gastroesophageal reflux disease were more likely to also report nighttime awakening, next day poor functioning, difficulty falling asleep, poor sleep quality, and overall decreased quality of life. Again, clearly suggesting the impact of nighttime GERD on patients' sleep experience and consequently on patients' perception of their quality of life. This is another study that we've done, a very large survey that included more than 40,000 subjects. When we looked at those that did have gastroesophageal reflux disease and we compared them to those who did not, then those that did have gastroesophageal reflux disease had twofold increased risk of experiencing sleep difficulties. 75% of them had increased risk of experiencing problems with sleep induction, meaning falling asleep, and 89% experiencing problems with maintaining sleep. Now, when we look specifically at the GERD group, we found out that those that have nighttime gastroesophageal reflux disease had 53% increased risk of reporting having sleep difficulties, 43% of having problems with sleep induction, and 56% in maintaining good sleep as compared to those that had only daytime symptoms. This is another study that we've done, again, a large study that included 25,000 patients. And we looked at factors that affected reports of heartburn that awakened patients from sleep during the night. And we found out that the most important ones were snoring and feeling sleepy, having insomnia, and the use of benzodiazepines. Benzodiazepines are commonly used as sleeping pills. And it appears that if you use benzodiazepines, then you're more likely to experience also heartburn that awaken you from sleep during the night. Others, and very important, are, for example, the consumption of carbonated soft drinks, and then hypertension and asthma, both disorders that require medications that can affect esophageal function. Now, we've initiated a series of studies in trying to further understand the relationship between gastroesophageal reflux and patient sleep experience. And for that purpose, we use what we call actigraphy. An actigraph is a watch-like device, like you see on the slide, which is worn on the non-dominant wrist and records motions with oscillometers that are present inside that watch-like device. And that device has been validated, and it's been shown to be equivalent to a sleep test in determining if patients are awake or asleep. Now, in addition, at the same time that we performed actigraph testing, we also did pH testing on our patient. And then we superimposed the information that we got from these two tests on the same strip, matched by time, in order to further understand the relationship between gastroesophageal reflux and patient sleep experience. And let me show you what we found out. Now, if you look at this, on the left side, it says whenever the patient had meal, which is the yellow color. Then whenever the patient was in supine, meaning that the patient was in bed, that was the green color. Whenever the patient was asleep, the blue color. And whenever the patient was awake, the white color. And if you look at the sleep period, you can see that at the beginning there is a green color. And if you look at the bottom, at the pH strip, you can see that there are a lot of reflux events, which are confirmed by the fact that the pH drops below 4, which is the definition of reflux events. So during the green period, which is when the patient was lying in bed but was awake, there were a lot of reflux events. Then the blue period starts, which means the patient was asleep. And you can see that during the blue period, there are 2 additional periods where the color is white, suggesting that these periods the patient was awake. And you can clearly see that they were associated with reflux events. So these are 2 awake periods that were associated with reflux events during sleep time. So let's go back and summarize again. So here we go. We see the green period with the reflux events. That's when the patient was laying in bed, awake before they fall asleep. This period was clearly associated with a lot of reflux events. Then these are the 2 periods where the patients woke up from sleep during the night, and they were also associated with reflux events, suggesting that during patient's sleep period, the patient had to wake up twice with reflux events, resulting in what we call sleep fragmentation. So patient did not have a nice, clear sleep period, but actually a fragmented sleep period, which most likely affected patient sleep experience. We looked also at the relationship between conscious awakenings and acid reflux events and symptoms. Conscious awakenings are awakenings of a certain duration, at least 2 minutes, and we call them conscious awakenings because the patients can recall them, because if the awakenings are too short, they tend to be amnestic and patients don't recall them. And these are also the awakenings that patients may experience symptoms, because you have to be awake in order to perceive symptoms. So we looked at our patient population and we found out that these patients experienced a total of 104 conscious awakenings. And of those, about 52% were conscious awakenings that were associated with acid reflux events, a pretty significant number. And then when we looked specifically at the conscious awakenings that were associated with reflux events, we found out that only 31.5% of them were associated with symptoms. So if we look overall at our patients, these were obviously all GERD patients, if we look at the whole 104 conscious awakenings, only 16.3% of them were associated with symptoms, suggesting that many of the conscious awakenings that were associated with reflux events that the patient experienced were not associated with symptoms, clearly suggesting that just waking up from sleep during the night could be a manifestation of gastroesophageal reflux disease without the need that the patient will also experience symptoms. This is another study that looked again at reflux, and they had 104 subjects with documented sleep abnormalities and no heartburn. In this study, they used sleep test plus pH test, and they found out that 26% of the patients woke up during sleep with reflux events, and these patients did not have symptoms, further suggesting the importance of sleep awakenings per se, without symptoms, as a manifestation of gastroesophageal reflux during sleep time. This is a very interesting case. This patient said that she was on fire most of the night. Now, if we look at the test again, as I mentioned, this test is the combination of pH test with an actigraph. You can see at the top, it says heartburn, there's the red line. This is the period of patient's sleep time that the patient reported having heartburn. Pretty significant period of time. Now, if you look, green is when the patient was in supine, sleep when the patient was asleep, and white when the patient had, when the patient was awake. And you can see that the patient had a very short period of being in bed and awake before they fell asleep. And even that period of time was associated with a lot of reflux. This is mentioned by the green arrow. The patient experienced 6 periods of conscious awakenings that were associated with a lot of reflux. And then eventually, after the last conscious awakening period marked by the letter F, then the patient was able to sleep throughout the rest of the night. But you can clearly see that during the period where the patient said that they were having a lot of heartburn, that was associated with the multiple conscious awakenings that were associated with a lot of reflux events, clearly explaining what happened in this patient during sleep time. Now, another question that we ask is, which is the chicken and which is the egg? Meaning, what do patients experience first? Reflux events and then awakening from sleep, or awakening from sleep first and then reflux event? And this study that looked at 104 conscious awakenings found out that in the majority, almost 90%, symptomatic acid reflux events developed after conscious awakenings. and not the other way around. So very rarely, symptomatic acid reflux event developed before conscious awakening. Of course, if patients experience a reflux event while they were asleep, as compared to while they were awake, the reflux events while they were asleep were of longer duration, significantly more than those while they were awake. For the simple reason then that when you are awake, you can initiate a variety of defense mechanisms like initiating primary peristalsis, swallowing saliva, and others. And then there is the concept of riser's reflux. This is another study that we performed, and we've shown that if you develop reflux before you wake up, then it's a relatively uncommon phenomenon, developing reflux while you're asleep. However, immediately after you wake up in our GERD patients, 33% of them demonstrated reflux events. And then 20 minutes after waking up, almost half of them demonstrated reflux events. So this study suggests that the transition between sleep and awake in the morning in GERD patients is commonly associated with increased reflux events, because studies have shown that sleep per se, especially deep sleep, is preventive of gastroesophageal reflux because it inhibits transient lower esophageal sphincter relaxation. Now, there are also what we call amnestic short arousals that occurred in GERD patients. So if the arousals are of a very short period of time, they tend to be amnestic, meaning patients don't recall them. But still, these arousals, even though they're very short, reflux can occur during that short period of time. And studies have suggested that 90% of acid reflux events were associated with these short awakenings from sleep. And most of these short awakenings from sleep did not last more than 30 seconds. And they occurred after an acid reflux event. And there were significantly more spontaneous arousals during pH drops than during comparison periods. So let's look at what we call the sleep and acid reflux model. It suggests that during sleep, there is a change in esophageal physiology, as I mentioned. And that change of esophageal physiology in patients with gastroesophageal reflux disease, it further exposed these patients with anatomic changes to develop gastroesophageal reflux disease. That increase in gastroesophageal reflux disease decreased patients' sleep experience, and decrease in sleep experience may affect gastroesophageal reflux disease. And let me show you the study that looks specifically at these questions. Can sleep deprivation or sleep deficiency per se can affect gastroesophageal reflux disease? Here's a study that was done in normal controls and patients with gastroesophageal reflux disease. Patients and control were exposed to bad sleep, which are 2 consecutive sleep periods where they were sleeping not more than 3 hours, which was confirmed by actigraph. And then they were compared to 2 good sleep periods where they were sleeping between 7 to 8 hours during 2 consecutive sleep periods, again, confirmed by actigraph. Then patients were brought into the lab. A probe was introduced into their esophagus and acid was perfused. And patients' sensation of this acid was assessed. And it was very clear that after bad sleep, after sleep deprivation, the acid perfusion sensitivity score was significantly higher, especially in patients. It was also in control, but not as much, as compared to after good sleep, suggesting that sleep deprivation may sensitize patients with gastroesophageal reflux disease, leading to decreased perception thresholds for pain, specifically for reflux. And that's been also demonstrated in other studies, not only visceral studies, but also somatic studies. Now, another study that we published recently, where we took just control subjects and we exposed them again to the same protocol of good sleep and bad sleep. Again, after each protocol, they were brought in and a probe was inserted into their esophagus, but this time, this was a pH probe. And then patients were tested over a period of 24 hours. Sorry, these were subjects, not patients. And we found out that about half of the normal subjects develop an abnormal esophageal acid exposure after bad sleep as compared to good sleep. So we could convert normal subject by sleep depriving them to an abnormal esophageal acid exposure. So we can see here two potential mechanisms that can lead sleep deprivation to affect patients with gastroesophageal reflux disease. So if we look at the sleep GERD model, we can see that this is a bidirectional relationship where sleep affects esophageal physiology. Esophageal physiology during sleep affect patients that have anatomic changes that expose them with gastroesophageal reflux disease. That increase in gastroesophageal reflux disease can decrease sleep experience, and that decreased sleep experience by itself can result in increased gastroesophageal reflux disease. There's always the question, obviously, here, which is the chicken and which is the egg, something that still need to be explored. This is another study, this time randomizing patients to dexlansoprazole, 30 milligram once a day versus placebo, given over a period of 4 weeks. And those that received dexlansoprazole, the median percent nights with heartburn was significantly higher as compared to placebo. The percent of patients reporting relief of nocturnal heartburn during the last 7 days of treatment was also significantly higher in the dexlansoprazole group. And the percent of patients reporting relief of GERD-related sleep disturbances during the last 7 days of treatment was also significantly higher in those that received dexlansoprazole as compared to placebo. The study also demonstrated that the main effect of dexlansoprazole was in those with moderate to severe or severe to very severe symptoms as compared to the effect of placebo, which was mostly on those with less than mild or mild to moderate. And this clearly showing the effect of dexlansoprazole as compared to placebo on various sleep disturbances. You can see significant improvement, for example, in nights with GERD-related sleep disturbances, nights with difficulty falling asleep, as well as many other sleep abnormalities. So when we look again at the bidirectional relationship model between sleep and GERD, we can see that one way to break this vicious cycle between GERD and sleep is to treat the gastroesophageal reflux disease in this situation with anti-reflux medication. The next question, of course, is, can we break this by just treating sleep per se? And this is a study that we performed where patients were randomized to either placebo or a sleeping pill, Rameltion, that was given 8 milligram once daily. Rameltion is a melatonin 1 and melatonin 2 agonist, and it's considered to be a sleeping pill. So both Rameltion and placebo were given to patients, and at 4 weeks, patients were assessed. And it appears that Rameltion significantly reduced reports of daytime heartburn and nighttime heartburn as compared to placebo. Let me repeat that these patients, patients that received Rameltion reported significant reduction in their daytime heartburn and their nighttime heartburn as compared to placebo. And also those that received Rameltion demonstrated significant improvement in their insomnia severity index. So when we go back to our sleep-GERD relationship model, one can see that you can break this vicious cycle by treating gastroesophageal reflux disease or by treating sleep. At least we have one study using a sleeping pill in the form of Rameltion. So let's conclude here. Nighttime GERD is associated with many sleep disturbances. Nighttime GERD and the associated sleep disturbances markedly improve with anti-reflux treatment. And there is a bidirectional relationship between GERD and sleep. GERD can worsen sleep quality, and poor sleep can independently worsen gastroesophageal reflux disease. And at the end here, I will say, never give up on your dreams. Keep sleeping. Thank you very much.
Good morning, and my thanks to the GALA conference organizers for having me today. I'd like to speak today about the updates in diagnosis and management of chronic pancreatitis. Chronic pancreatitis is one of the most challenging diagnoses in the pancreas to manage. And I'll start this morning by briefly reviewing the epidemiology of chronic pancreatitis and the clinical presentation, diagnosis, etiologies, and risk factors, as well as the natural history of the disease. But I really want to focus on the management of pain, malabsorption, and pancreatic cancer surveillance, and finish with when to refer for advanced endoscopy and surgical procedures. Chronic pancreatitis is a fibroinflammatory syndrome of the pancreas in individuals with genetic, environmental, and other risk factors who develop this persistent pathologic response to parenchymal injury and stress. And this leads to irreversible morphologic change, fibrosis and inflammation, and typically pain and permanent loss of exocrine and endocrine function. The epidemiology data comes mostly from large case series and cross-sectional studies. So a population-based study out of the Mayo Clinic found that the incidence is about 4.4 to 11.9 per 100,000 per year, with a prevalence in Olmsted County of 36.9 to 41.8 per 100,000. It does tend to favor men by a factor of 1.5 to 3, and the median age or the mean age of diagnosis in North America is about 47 years old. Despite the relatively low prevalence of the disease, it's responsible for 56,000 admissions per year in this country and costs the healthcare system over $150 million annually. Chronic pancreatitis has been associated with about a 55% mortality at 20 years from the time of diagnosis, not necessarily from chronic pancreatitis itself, but primarily due to infection, malnutrition, and complications from recurrent pancreatitis. Chronic pancreatitis can result from recurrent episodes of acute pancreatitis. So acute and chronic pancreatitis can really be thought of as on a continuum. So there are two processes on the same spectrum of disease. Many of the clinical features of chronic pancreatitis take time to manifest. So while it's easier to make the diagnosis when end-stage features have developed, the goal is actually to make an accurate diagnosis early on in the clinical course when interventions might actually change the trajectory of the disease and prevent progression to the end-stage disease. So the diagnosis of chronic pancreatitis really should be considered when there have been multiple episodes of recurrent acute pancreatitis. Although it's important to keep in mind that some patients do develop it without having developed acute pancreatitis. Abdominal pain, as with most things pancreas, is the most common clinical symptom. The pattern of this pain varies. Some patients have type A pain, so discrete episodes of pain with prolonged pain-free periods between these exacerbations, and others have type B pain. So they experience constant pain of variable severity with these periodic exacerbations. Type A and type B are not the only types of pain. Really, pain can occur on a continuum ranging from no pain to constant severe pain. And these pain patterns can actually change over time, usually evolving to be more continuous. Chronic pain of any type is the major driver of decreased quality of life, and the presence of pain and severity of pain don't necessarily correlate with the severity of disease seen on imaging studies. Other symptoms to be aware of: nausea, vomiting, signs of pancreatic insufficiency, weight loss, bloating, and cramping are all possible. The diagnosis of chronic pancreatitis has been difficult because there is actually a debate about what the gold standard is. So in patients with clinical symptoms, cross-sectional imaging should really be the first test used to develop the diagnosis. It's universally available, it's reproducible, and it's pretty valid. CT is most frequently used. On this CT, you can see that the red arrow points to a pancreas that's atrophied. There's ductal dilation, and you can see multiple calcifications in the pancreas. The most common CT findings really are those three: the dilated duct, pancreatic atrophy, and pancreatic calcifications. Other CT findings include fluid collections, focal pancreatic enlargement, biliary duct dilation, or alterations in peripancreatic fat. And the overall sensitivity of CT in diagnosing chronic pancreatitis is about 80 to 90%, with a specificity of about 85%. CT is better for changes of the pancreatic parenchyma in late stage chronic pancreatitis, and it tends to be a little less reliable for looking at the pancreatic ducts. Pancreatic calcifications on CT are more commonly seen when alcohol, smoking, or hereditary pancreatitis are the etiologies. When the diagnosis can't be made on CT alone, MRI and MRCP can also be used. MRI findings of chronic pancreatitis include low signal intensity pancreas on T1 weighted images and decreased or delayed enhancement after giving IV contrast. And there are some changes to the pancreatic duct as well, including dilated side branches or dilation of the main pancreatic duct. There's progressive parenchymal atrophy as the disease progresses that can be seen in the pancreas itself. And it's important to note that the progression of gland morphology on these imaging studies doesn't actually correlate with pain or changes in quality of life. There's a Scandinavian study that followed about 25 patients for 4 years with MRI. And during the course of follow-up, they saw changes on MRI, including reduction of pancreatic volume, increase in fibrosis, but this didn't affect the clinical symptoms at all. Secretin-enhanced MRI is a non-invasive way to evaluate the pancreatic exocrine function. Secretin is a hormone that stimulates the pancreatic duct to release bicarbonate-rich fluid into the ducts and then the small bowel. And this helps to make a diagnosis of chronic pancreatitis in 2 ways. The first is that the exogenous administration of secretin allows for better visualization of the main and side branch ducts and really highlights pancreatic duct strictures. And the second is that it allows you to quantify the degree of filling into the duodenum. So the volume of fluid secreted from the pancreas in response to secretin provides a functional analysis of pancreatic exocrine function, and it correlates with the severity of the disease. So the less fluid that is secreted into the small bowel, the more pancreatic exocrine function is impaired. There haven't been randomized controlled trials that have specifically compared cross-sectional imaging with endoscopic ultrasound for diagnosis of chronic pancreatitis. And given the fact that it is an invasive procedure, US is usually only used when the diagnosis is still in question after cross-sectional imaging. There are 9 total US criteria, 4 for the parenchyma and 5 for the duct. And the ideal threshold number of US criteria to make a diagnosis has really not been firmly established. We think that the presence of 5 or more criteria really strongly suggests the diagnosis of chronic pancreatitis, and having 2 or fewer pretty strongly refutes that diagnosis. Parenchymal abnormalities include hyperechoic foci, hyperechoic stranding seen in boxes A and B here, pancreatic cysts, lobularity of the contour of the gland, and ductal abnormalities include main duct dilation, duct irregularities, side branch dilation, stones, and hyperechoic duct margins. Limitations of EUS, obviously, it requires somebody trained in EUS, and the test is operator dependent. There's some controversy on the use of pancreatic function tests to make a diagnosis of chronic pancreatitis. Because of the large reserve within the pancreas, the sensitivity of pancreatic function tests to make a diagnosis can be low. It's done either through intraductal or duodenal sampling of pancreatic juice, and either secretin or CCK are used. So secretin stimulates the ductal cells, and you measure the volume and the bicarbonate concentration endoscopically. Cholecystokinin stimulates acinar cells, and the enzymes, so either trypsin or lipase, are what is measured. And these tests can be fairly cumbersome to do, and they're not really that widely available, but they do have fairly high sensitivity for detecting late chronic pancreatitis, but lower sensitivity for early disease. Indirect pancreatic function tests, these don't require direct hormonal stimulation of the pancreas, and they're generally more available and obtainable, so they can be used as adjunctive tests. Traditionally, serum trypsin or trypsinogen were measured, but these aren't really currently used because they can be elevated in non-pancreatic pain syndromes and have a pretty poor correlation with imaging findings. Stool-based tests are super common. The 72-hour fecal fat measurement might be considered a gold standard for steatorrhea, but practically speaking, it's very difficult to do. So fecal elastase is much more commonly used. There's a direct correlation between pancreatic and stool concentrations of elastase. Normal is anything greater than 200 micrograms per gram of stool. If you lower that threshold to 100, this improves specificity, but lowers sensitivity. Anything less than 50 micrograms per gram of stool is probably clinically significant. Fecal elastase is not impacted by pancreatic enzyme replacement, so can be used in patients on Creon, but it has to be done on a solid stool, because if the stool is diarrhea-like or liquid, the test can be artificially low or dilute. Histology traditionally has been seen as the gold standard to diagnose chronic pancreatitis, but the sensitivity is actually pretty low. And unlike with liver biopsies or other biopsies, histology from the pancreas here doesn't give you the etiology of the disease. What the histology traditionally shows is loss of acinar tissue or atrophy, fibrosis with perilobular or interlobular collagen, and chronic inflammatory infiltrates. A lot of these diagnostic features that I just mentioned are actually really only seen in advanced stage chronic pancreatitis. So diagnosing early stage disease is much harder. And early here refers to the disease state and not necessarily the duration of the disease. So to address this, the International Pancreas Group established these consensus guidelines for diagnosing early chronic pancreatitis, and they combined imaging features with other clinical and functional features, including recurrent abdominal pain, abnormal serum or urine enzymes, abnormal exocrine function, and continuous heavy drinking as ways to make a diagnosis earlier. Once you've made the diagnosis of chronic pancreatitis, a comprehensive review of all risk factors should really be performed to look for an underlying mechanism and to identify any modifiable risk factors. And so the TIGER-O system is what has been used to characterize the etiologies to explain chronic pancreatitis. T for toxic metabolic, alcohol, smoking, hypercalcemia. I for idiopathic disease, G for genetics, A for autoimmune, R for recurrent or severe acute pancreatitis episodes, and O for obstructive, so pancreas divisum, sphincter of Oddi dysfunction, or duct obstruction. There are a couple of key risk factors that are important not to miss in the clinical history, and these are namely alcohol and smoking. Alcohol is the single most common etiology risk factor, and there's a clear threshold of 4 to 5 drinks per day that clearly increases the risk of disease. Smoking is the other big risk factor, and this presents in a more dose-dependent manner. And so we know that if you smoke more than 1 pack a day, there's a 3-fold increased risk of developing chronic pancreatitis. And for smoking, stopping actually helps because cessation of stopping reduces that risk by up to 50%. Genetic testing is recommended in patients who have chronic pancreatitis in which the etiology is unclear, especially if they're younger patients. So multiple genes have been identified to be associated with chronic pancreatitis, and they're primarily linked to the trypsin pathway, including PRSS1, SPINK1, and CFTR variants. And it's thought that these genetic factors, that there's a 2-hit pathogenesis. So there's pre-existing pancreatitis risk factors. And then there's the initial first acute pancreatitis hit that activates the immune system. And afterwards, these patients either recover or they go on to progress to chronic pancreatitis. Testing for these germline mutations helps to determine the pretest probability of true chronic pancreatitis in early stages of the disease, and it may help identify the pathologic pathway as well. Hereditary pancreatitis affects about 3 to 6 million people per year and are related usually to a mutation in the PRSS1 gene, which is on the long arm of chromosome 7. So this is a autosomal dominant gain of function mutation. So mutated trypsinogen is activated to trypsin too easily, or it's resistant to inactivation, and this leads to pancreatic injury. Patients with PRSS1 mutations are at increased risk for acute and chronic pancreatitis, but they also have a significantly higher risk of pancreatic cancer. So 40% of them actually go on to develop pancreatic cancer by age 70. There are 2 other variants of chronic pancreatitis to be aware of. Groove pancreatitis is an anatomical variant of chronic pancreatitis, primarily involves men ages 40 to 50, and there's a strong correlation with tobacco and alcohol use. And this is a chronic inflammatory process that resides in the duodenal submucosa, the duodenal wall, or the adjacent pancreatic tissue. And the other type to be aware of is autoimmune pancreatitis. This is the pancreas manifestation of IgG4 related autoimmune disease. And the prevalence can be about as high as 3 to 5%. And this often presents with painless jaundice or a pancreatic mass. CT findings show classically a sausage-shaped pancreas plus or minus a halo sign. And this particular type of chronic pancreatitis is treated with steroids. After making the diagnosis, it's important to understand the natural history of the disease process, including pain, pancreatic insufficiency from loss of acinar cells leading to decreased insulin production, exocrine insufficiency, as well as metabolic bone disease, malabsorption, and the risk of pancreatic cancer. Pain is the most common feature and probably the most detrimental to quality of life. The pain of chronic pancreatitis is a really complex multi-level neuropathic pain syndrome. It involves the cerebral cortex with central sensitization. It involves the peripheral nervous system with spinal cord hypersensitivity, and it also involves intrapancreatic neuropathic mechanisms. The response to therapy for chronic pancreatitis pain is really unpredictable, it's inconsistent, and it's often inadequate for these patients. There's a really high addiction potential, and there's also a really high placebo response of 20 to 30%. It's been suggested in the past that the pain of chronic pancreatitis will improve over time as the pancreas burns out, so to speak, but this finding has really not been reproduced in further observational cohorts. The overview of treating pain then really progresses in a stepwise fashion. So holistically, you want to think about removing the offending agent, counseling to stop smoking, stop using alcohol, and then work on analgesia and malabsorption. And lastly, moving on to procedures to either decrease pancreatic pressure or surgical procedures to remove parts of the pancreatic parenchyma itself. Analgesia, stepwise fashion. Start with Tylenol, NSAIDs, Tramadol, and then add adjunctive therapy to those who have worsening pain or increasing pain medication needs. And the adjunctive therapy most commonly used are pregabalin, gabapentin, SSRIs, and SNRIs. There's only been one randomized trial on the use of pregabalin, and it was actually funded by Pfizer that makes the medication. They randomized 64 patients to get either pregabalin or a placebo and measured short-term outcomes. So the outcome at 3 weeks was that these patients had a decrease in opioid requirements and decrease in pain scores, but more adverse events. And these adverse events really related to side effects of the medications. Do pancreatic enzymes decrease pain? Probably not. And certainly if a patient is already on heavy-duty narcotics, the enzymes are not going to touch pancreatic pain. The physiology behind this theory was that enzymes cleave CCK-releasing factor peptide and decrease stimulation, but studies have really not panned out for the use of enzymes for pain. They are, however, important for malabsorption from exocrine insufficiency, and both national level as well as single center studies have shown that we're probably not testing enough people for exocrine insufficiency. And many of those people who do have exocrine insufficiency are probably not getting adequate doses of enzyme replacement. What is sufficient dosing? The normal pancreas makes about 900,000 units of lipase per meal, and you need about 10% of this for normal digestion. So presuming that the pancreas still has a tiny bit of function left, we generally start with 50 to 75,000 units of lipase per meal and 20 to 35,000 per snack. These enzymes are temperature sensitive, they do degrade with time, and they do have a limited time of effect. The use of antioxidants can be considered, though the benefits in pain reduction are probably limited. The exact mechanism by which they reduce pain is unclear. It's thought that maybe they reduce oxidative stress, and this provides some amount of anti-inflammatory effect. These antioxidants are not FDA regulated. And there have been two big studies, one pro, one con. So a study out of India was placebo-controlled, double-blinded, randomized 147 patients. And they found at 6 months of follow-up that there was a reduction in the number of painful days in patients who took antioxidants. A couple of years later, a group out of the UK did the Anticipate study, also double-blinded RCT, 70 patients, but they found no change in pain or quality of life. And so generally, if antioxidants are used, they should probably include the antioxidants in these studies. So selenium, ascorbic acid, beta carotene, and methionine. But remember that none of these are FDA regulated. Bone health in chronic pancreatitis is important. We're probably not doing enough of it. The risk of osteoporosis and fractures here is similar to in IBD patients, probably because of fat-soluble vitamin deficiencies and zinc and magnesium deficiencies leading to malnutrition. So patients should be on vitamin D and calcium supplementation. They should have baseline bone mineral density testing, and the fat-soluble vitamins and zinc, as well as exocrine and endocrine function, should be assessed regularly. There's very little good evidence about whether to do screening exams for pancreatic cancer in all patients with chronic pancreatitis. So generally, the recommendation is that for those with inherited PRSS1 mutations, surveillance is probably needed and should probably be done, but we don't know what the best method is. We start this usually at age 40 and stop when the patient is no longer a good surgical candidate. Once you've addressed the pain and malabsorption, it brings us to the question of what is the role of endoscopy and surgery? Endoscopic and surgical management is really only indicated for severe persistent pain. It's not for asymptomatic chronic pancreatitis, and it does not improve exocrine or endocrine function, and it certainly does not prevent pancreatic cancer. Anatomy is important. So if there's an inflammatory mass in the head of the pancreas, surgery is probably the way to go, traditionally with a Whipple. There have been a couple of modification surgeries to make it an easier surgery and remove just the diseased portion of the pancreatic head. So the Bager procedure is one of those. It removes almost all of the head of the pancreas, but it saves the duodenum, the stomach, and the bile ducts. The Fry procedure cores out the pancreatic head, and the jejunum is brought up laterally to drain the duct. And the Burn procedure is really a modification of the Bager and the Fry. When you have a dilated duct, this is really where you need a plumber. So endoscopic decompression of the pancreatic duct can be used for immediate pain relief, and patients are then offered surgery if endoscopy fails. Surgery is also really useful if there's significant calcifications or a mass in the head of the pancreas. And the surgery that's most often done here is the lateral pancreaticojejunostomy, or the modified Pusteaux. So this is where the main pancreatic duct is opened from head to tail and connected to a loop of small intestine. So the pancreas drains directly into the small intestine. Which one should you do, endoscopy or surgery? A couple of trials have looked at this. This one randomized 39 patients to either endoscopy or surgery, followed them for 24 and 79 months. There was a follow-up paper, and found that surgery was more effective for long-term pain relief at both follow-up points. And actually, patients who had endoscopy first, almost half of them went on to require surgery. More recently, the ESCAPE trial looked at the same question. 88 patients randomized to endoscopy versus surgery, found that the group that had surgery had better long-term pain relief. Practically speaking, though, even though the surgical approaches are shown to be better for long-term pain relief, They're rarely done first line, and surgeons often operate only after endoscopic approaches have been unsuccessful. So it's reasonable to do an endoscopic drainage procedure first with the plan for surgery if that doesn't work. Celiac plexus block refers to the injection of pharmaceuticals into and around the region of the celiac ganglia, can be considered in patients with a significant amount of abdominal pain who are not candidates for surgery or who have not responded to endotherapy or extracorporeal shockwave lithotripsy. And in patients who have poor general conditions, it can be used as a temporizing measure before more definitive surgery. Realistically, it's a relatively low risk opioid-free method that reduces refractory pain, though it's not entirely clear which patients derive the most benefit. In small duct disease, this is really more medical management of pain, and surgery is more either to remove a portion of the pancreas with the V-plasty or taking out the pancreas completely with or without islet cell autotransplantation. Total pancreatectomy with islet autotransplantation really should be considered only in patients in whom all medical treatment has failed. The main indication is debilitating pain, and there may be a lower threshold for the procedure in patients with hereditary pancreatitis. Major contraindications and poor candidates for this surgery are alcoholism, pancreatic cancer, any sort of end-stage systemic illness, or psychiatric or socioeconomic status that really precludes the performance of surgery or the care afterwards. TPIAT is a procedure whose outcomes have really not been subject to extensive review. Most of the data comes from cohort studies. There's really only been this one meta-analysis of 15 observational studies. It did show improvement in opioid-free rates at 1 year, and it did show a decrease in insulin-free rates. There's almost certainly a publication bias that's going on here, so it's critical that at some point we evaluate the comparative effectiveness of TPIAT to more traditional surgeries. So TPIAT, really only consider it in really well-defined selected cohorts, young age, before multiple endoscopic attempts, and before they've had any activation of neuropathic pain circuits. And this probably is what leads to better outcomes. So to summarize, approach the management of chronic pancreatitis by finding the etiology if possible. All patients should be counseled to stop smoking and to avoid alcohol. And remember that the pain of chronic pancreatitis is a complex multi-level neuropathic pain syndrome. Remember the diagnostic and treatment approach according to the anatomy, and be sure to monitor for complications, including endocrine and exocrine insufficiency as well as bone health, and treat all of those accordingly.
See you guys partying while we were watching the last video. And Dr. Yang, I'm wondering whether I'm paying you too much given your background there. Dr. Fass, your study on Dexilant, when was this given, and your thoughts on when to take the PPI for nighttime symptoms? Remember, those of you attending virtually can submit your questions. They will be magically passed to the iPad in front of me and inquired on your behalf.
Yeah, the answer is that the Dexilant was given in the morning. Now, even though Dexilant can be given without relation to food, as it is mentioned, I think it's preferable to give it in the morning, half an hour before breakfast, like we do with the other PPIs. So that's how the study was done. Now, in general, if you have PPIs and patients have primarily nighttime symptoms, then I prefer to move the PPI to half an hour before dinner, if that's the case. But in the case of Dexilant, because of its dual delayed release technology, I would give it in the morning, half an hour before breakfast.
And I guess there's a second question. You're gonna have to mute when I'm speaking. A second question as to why certain PPIs are better than others.
So if you if you ask me if there are certain PPIs that are better than other, I just say that PPIs have some differences in pharmacokinetics and pharmacodynamics. In order to show differences, studies have to recruit thousands of patients, suggesting that overall, if you look at PPIs, when you look at their clinical effect, it's probably about the same.
While we're waiting for more questions coming in, Dr. Yang, in the days when I managed general GI problems, chronic pancreatitis patients were among the most frustrating to deal with because they came in with pain all the time and often with minimal or no amylase or lipase elevation. How do you tell whether it's really a relapse of chronic pancreatitis versus just a pain syndrome that's going to lead to opioid-induced esophageal problems that we'll have to deal with in the next few months?
It's a good question. It's very difficult to tell. So there's certainly a huge overlap between the pain of chronic pancreatitis as well as the central sensitization. And so it's probably both. There's probably actual pain that's going on in the pancreas. And then because of the involvement of the peripheral as well as the central nervous system, the nerves get so used to the pancreas sending out signals of there's going to be pain, there's going to be pain. So they're already sensitized. And even if there's no pain signals coming out of the pancreas itself, there's peripheral and central sensitization to the pain. So there's probably both processes going on, which also is why that there's a huge addiction potential in the disease. There's a recent study out that actually also shows a pretty significant overlap between people who are susceptible to chronic pancreatitis and people who are susceptible to depression. And so that's also probably contributing to the pain syndrome as well. And so it's multifaceted treatment. Treat the actual pain. They're probably not going to have the lipase or amylase elevations. And this is where I really like to add the neuromodulators, like the Lyricas or the gabapentins, to try and modulate that central sensitization as well.
Yeah. If I may say something regarding that question, because this is clinically real in that we face this with patients with inflammatory bowel disease, with chronic pancreatitis, because there's true disease in the background, and then patients are clearly on opioids, and how that dynamic of how do you know the patient truly needs it is a real problem for inpatient care. Patients are admitted to the hospital, then there's an expectation of use of opioids. And that's where we've been for the past couple of decades at least. And that's what's created this opioid crisis that we talk about and we've heard about. And that really is I personally wish we had a way of saying, is there true disease? Is there true pain that one could then treat appropriately versus not? But it is a real problem.
So while you're sitting, by the way, I will say that's one of the comfiest looking chairs I've seen. I'm going to have you email me where you got it so I can get one from my pad. When we talk about opioid-induced GI motility disorders, whether it's upper or lower, one of the goals in opiates is to get them on opiate substitution therapy. When you look at methadone and Suboxone, is there any difference from the other opioids in terms of which will affect the GI tract more or less, and any difference between methadone and Suboxone?
The data are not really strong on those, but I think on a couple of the slides that I presented, there's tramadol and then there's codeine. There are studies on that, and they are not. So the partial agonists are going to be better than your full, and that's where the data are the strongest. So if there's any way that one could go to the partial agonist, the impact we do know are going to be less. We don't. This is all new in the past, I would say, a couple of years where we really recognize this association between GI motility. We've always known this for constipation. That is where the data are the strongest. We don't have it for the upper gut problems, and that's where we really, if possible, and that's the big if, because we all know that many of our patients really that have this problem are going to have a hard time getting off of these pills. It's an addiction. And if you can get them to partial agonists, that would be great, because the impact we do know would be less.
So that would support probably Suboxone being
Suboxone would be
better.
Yeah.
Sounds
we
like
don't have data specifically, but we do know partial would be better.
well, sounds like I've just given you an idea for your next research project.
There you go.
Well, you'll have to give me an acknowledgement when you have a paper in the New England Journal. Any other questions, either from the audience here or virtually from outer space? Oh, here's one. By the way, those were excellent lectures. I wish I hadn't just taken my GI boards, because I'd be a little smarter now, probably get a higher score. Oh, this is a probably a question we all want to know the answer is, how long is it safe to take a PPI? And I'm going to add to that, when you want to stop a PPI for the 90% of people who are taking it without a clear indication, the 90% is editorial. How do you get people off of PPI?
So how long you can, the first question obviously is how long you can take a PPI. And so I would say as long as you need it. So the rule is that if you need a PPI, then you should take it. And if you take a PPI, you should take probably the lowest dose that control your symptoms. That's the kind of the basic concept. We've seen more and more patients that are coming from primary care. And there was also a recent paper that was published in Gastro 2 months ago showing a marked decline in prescriptions that were provided by primary care physician and internal medicine. So there is an overall trend amongst treating physicians to start and cut off PPIs from patients. And I think many times for no good reason. It is just based on the data, this retrospective data that we've had about the chronic risks of PPI treatment. So I would just like to emphasize again, one should be treated with the PPI as long as they need it and with the lowest dose that control their symptoms. Now, the second question, when should you stop the PPI? Now, personally, the way I approach it, I don't taper down patients unless they're on double dose. If they're on once a day, I just tell them if they want to stop the PPI or they need to stop the PPI, they can just stop it. If they have any problems with that, they can taper it, take it every other day, then 3 days, and then add H2 blockers. But I have to say that most of the time we can get away by just asking the patient to stop the PPI.
Allison, role of Cymbalta and abdominal pain with chronic pancreatitis, and if there is a role, what is the mechanism?
It's a good question. We don't have data on that, unfortunately. The only data we have is that one trial on pregabalin. There's thought that all of the SSRIs, NRIs probably have some effect on the GI system, probably through some sort of neuromodulation. So I have had patients who are on Cymbalta or other medications of that type, Prozac, Zoloft, who have some improvement in their chronic pancreatitis pain symptoms. It may have to do with that overlap between chronic pancreatitis and depression as well. I'm not sure we know the mechanism in how it actually affects chronic pancreatitis symptoms.
I'll ask a question that was asked of me this past week in the office. PPI and COVID-19 risk, real or fake news?
So that's a very good question. So we're very well familiar with the paper that was published by the CEDAR group in the American Journal of Gastroenterology. I think that if you look at the paper and you look at the data, and I've recently discussed it extensively, I think we cannot conclude based on that paper, in my mind, if patients that are treated chronically with PPIs have increased risk to be exposed to COVID-19. So all I would say is that we need more studies to look into it.
Lisa, are you telling me that something is supposed to show up on my iPad? Well, that is not true. You're going to have to do better. Not only that, I have no clue when we're supposed to stop the Q&A period. Though I do have an announcement for the end. Try again, or I'll reload. I wish I had a joke about two snails and a slug, but unfortunately, I don't.
Can I just piggyback on what Ronnie said about the
Sure.
PPIs? Yeah, I agree with him 100%. The other issue to realize is that there was a study that said somehow H2 receptor antagonists are protective and actually help. So that really gets to the biological plausibility of this association, right? So how is it that by suppressing some acid, it's actually good, i.e. helps you with COVID and helps you recover from. However, suppressing a little more, it's bad. So to me, that gets to the biological plausibility, just like some of the studies, initial studies with PPIs showed that one PPI was bad for pneumonia, the association with pneumonia, while the other one was protective. So again, these are associations that have to, at the end, make sense. And they somewhat are falling apart in some of the analyses that come forward. And there's very weak associations.
Good. That was what I told the patient. I said I didn't believe it, but that if she wanted to take famotidine, her symptoms wouldn't go away, but she would then be protected from the COVID, allegedly. All right. So here, this is a multiple question. Does it make a difference which PPI used for nocturnal reflux, and what about alginates? And then I guess there's it's probably supposed to run upward. Adjunctive therapy for nocturnal GERD, H2 blocker before sleep, or an alginate.
Yeah, so in relation to what PPI to take, I think I don't have any preference from a PPI point of view. I think they all do a good job in treating nighttime GERD. And in fact, many of the pivotal trials that looked at PPIs in patients with gastroesophageal reflux disease also looked at their effect at nighttime, and they all had, I have to say, about similar effect. In relation to what to use at bedtime, and so we traditionally use H2 blockers. We add an H2 blocker at bedtime. You all know that ranitidine was removed from the market, so it's primarily famotidine, and as you said, now it will have dual effect. Not only it will protect you from nighttime symptoms, it also protect you from COVID-19. So, the only thing about giving patients H2 blockers at bedtime is the tachyphylaxis effect, and it's something to bear in mind. I would just say that if you give patient on a regular basis an H2 blocker at bedtime, maybe have kind of a drug holiday once in a while in order to prevent tachyphylaxis, because it develops very quickly, relatively quickly. In relation to alginate, there are studies of using alginate as an add-on to PPI with success, not specifically for nighttime GERD. So I cannot really say if it is really a good medication just specifically for nighttime reflux.
Do we have any other questions here in the audience? We'll give a moment for the people to type in. Otherwise, for the virtual attendees, I hope you will, that you can't do the breakouts. That's restricted to the people, the wonderful people here in this audience who get the pleasure of me or some other person. I think there are other breakouts besides me. I don't know if they're any good, but no, they're fine. They're excellent. It won't be that much worse than if you're with me. And then you can come back at noon, whether you're virtual or in person, for more me. We're going to do a lunchtime product theater on PBC. And then the CME program will return at 1, where you'll have not me again. So when we're done here, I have one other question. I will go out to our breakout sessions, come back for lunch. You guys will be free to enjoy your days wherever you are. What is the most common motility disorder of the esophagus in patients with chronic opioid therapy? And I would say that what should make you think that that is the problem rather than something else? And someone who comes to you obviously has pain, they're on opioids, and says, now I have, what should lead to the evaluation of a motility disorder?
Yeah, it's really, I would rephrase that question and sort of, because you're absolutely right, whoever asked this question, the patient's going to come in with the same symptom as your typical echolalia, right? So your idiopathic echolalia is going to come in with dysphagia to solids, liquids, regurgitation. So will the patient that's been on chronic opioid. Where you're going to need to really be more focused on, and some of the data are suggesting because of this association, is when you do diagnose someone with hypercontractile state, whether it be echolalia, whether it be spasm, whether it be EGJ outflow obstruction, to ask the patient and or look at their medication list. So it's really, that's where you start wondering whether or not it's the impact of the opioid. Then you ask the question, how long have you been on it? Because you won't just from the motility know and distinguish one that's idiopathic versus one that's due to opioids. So it's a recognition of the fact that the patient's been on it. And the problem is our treatments are really, how do you treat the patient, right? Obviously you want to take them off, but it's going to be tough, as we said. Can you go to the partial agonist if you can? And that's in collaboration with whoever prescribed the pain, if it's a pain team that's been involved. And at the end of the day, you're left with some of the similar therapies. Where I think you have to be hesitant on aggressive treatment of these patients is if pain is the driver rather than dysphagia. So these hypercontractile state, dysphagia is going to get better with some of your treatments, such as dilation, Botox, or if you have to do pneumatic dilation or POEM, dysphagia will improve. And if you can't get them off opioid. However, pain will not. So pain is going to be a tough one. It would, similar to what Allison was mentioning about chronic pancreatitis. It's just hard to treat pain if it's really related to the opioid dysmotility. So I would say just reversing that. And anytime you make a hypercontractile diagnosis on motility, be cognizant if the patient's on opioids or not.
So, but in terms of what the trigger should be for the evaluation, it's really dysphagia rather than pain. So someone says, I have pain right here in my chest and I'm on opioids, I need more, which is probably the complaint, then that wouldn't lead to a motility evaluation only if they have pain and dysphagia? Am I summarizing that correctly? Or is there a pain syndrome alone that would lead you to do a motility assessment?
No, the indication is no different than what we've been using. So if there's chest pain, you still have to do your cardiac workup that it's negative. Then if you suspect reflux, you treat for reflux. Then if it's not cardiac, it's not reflux, you do motility. And that's when, if you find motility disorder, you have to be cognizant that no matter how you treat that, pain may not get better. But if there's a component of dysphagia and pain, then the dysphagia is more likely to improve.
All right. Well, I want to thank the three of you for excellent presentations and this interactive Q&A. Thank the audience for your attention. You can proceed to your breakouts and then come on back here at noon. And for the virtual attendees, come on back at noon for what I promise will be an engaging lunchtime lecture and then an afternoon of further GI and liver disorders. And thanks to our sponsors and our organizers, and have a pleasant morning.
Hello, everybody. I'm I'm Dr. Razvan Arsenescu. I'm the speaker today, moderator for the section on inflammatory bowel disease. I'm the chief of the Atlantic Digestive Health Institute at the Morristown Medical Center, and also director of the IBD Center of Excellence. So this afternoon, I'll have the pleasure to introduce distinguished faculty that will discuss on very hot topics in inflammatory bowel disease. Dr. Lichtenstein is going to talk about choosing therapy based on a perceived outcome of the ulcerative colitis and Crohn's. Dr. Hanauer will talk to you about the treat-to-target strategy. And Dr. Binion will talk to you about the post-op care of IBD patients. And finally, I will conclude with the application of diet, understanding diet in inflammatory bowel disease. And hopefully we'll see how it matched with your choices today at the lunchtime. So without further ado, I'm going to introduce Dr. Lichtenstein now, and he'll discuss the therapy based on prognosis of IBD.
Hello, welcome everyone to the IBD section. This afternoon, I'm going to be talking about selecting therapy based on prognosis. I'm Gary Lichtenstein. I direct the Inflammatory Bowel Disease Center in the University of Pennsylvania Health System in Philadelphia, Pennsylvania. And I think you're in for a real treat with this section. My disclosures are before you. And I'd like to focus on certain areas. When treating IBD patients with medication is symptom resolution an adequate endpoint? And I think simply stated, the answer is no. And if we look at this historical study by the GERD study group led by Dr. Robert Modigliani, this is a very historic study. And it showed essentially that individuals that had Crohn's did not have a good correlation with symptoms and with the presence or absence of inflammation. And the CDAI represents the Crohn's Disease Activity Index. The CDEIS is the Crohn's Disease Endoscopic Index of Severity, which is a validated endoscopic index. And you can see the R value is 0.13, suggesting no correlation. So this is with Crohn's disease. And if you look at other studies that are looking at ulcerative colitis, you get a similar concept. In a recent meta-analysis that looked at 9 studies, the pooled prevalence of irritable bowel syndrome symptoms was over 30% for patients in remission. In other words, they had symptoms related to the presence of GI symptoms such as diarrhea, and they had no actual inflammation present. And if you look at the Act 1, Act 2 studies, these are studies that led to registration for infliximab in ulcerative colitis. Nearly twice as many patients had mucosal healing as had clinical remission. And you can see this in the figure on the right. Placebo is purple. Red is infliximab 5 milligrams per kilogram. The blue is infliximab 10 milligrams per kilogram. And if you look at the top, this is remission. The bottom is mucosal healing. So we see that the number of individuals that had mucosal healing is such that it is less than those that had actual symptoms. So the symptoms are more prevalent in people, despite having mucosal healing, they still have symptoms. If we look at the endpoints that are appropriate to achieve, this is an important component of how we attempt to treat our patients. And we have 3 pillars of IBD care, and we communicate these to the patients directly. Early intervention, treat to target, which will hear Dr. Hanauer talk about, and tight control. And these are not just represented for IBD. This could be termed for many other disease states, such as diabetes mellitus, rheumatoid arthritis, and a host of other conditions where we recognize these are critical components in adequate and appropriate care. In this schematic, you can see Crohn's disease represented over a period of time. On the x-axis is time, and on the y-axis is activity, disease activity, if you would, or surrogates of disease activity. So if you start on the left, this is when the disease is initiated. It's often subclinical, and then subclinical information comes about. And then at the time the diagnosis occurs, you achieve that certain threshold that leads to evaluating the patient, such as diarrhea, abdominal pain, that leads to endoscopic intervention and studies to see if there is actual inflammation. And over time, this can progress to simple complications: stricture, fistula, abscess, may need surgery or neoplasia. And the late disease is when the disease becomes less reversible. Early on, it's reversible. So if you see here in the yellow window of opportunity, that's the time we have where we can modify the disease. And we have good therapies that'll do that. Disease modification in Crohn's is highlighted here. So again, you have disease initiation on the x-axis, subclinical inflammation and diagnosis. But what if you do? What happens if you initiate a therapy that is disease modifying? You can keep it such that what you have is no damage to the bowel. You get rid of the inflammation, which lends to less fibrosis, less scarring, and perhaps there won't be fistulae or other complications that ensue as a consequence of adequately tight controlled disease management. Ulcerative colitis is the same. So that first two slides I showed represented Crohn's disease. In a similar vein, although we typically don't get strictures, one can get strictures in ulcerative colitis, but then you question, is that a malignancy? And recognizing approximately a third of patients who harbor strictures in ulcerative colitis have neoplastic complications. So a high index of suspicion when a stricture is seen is to say either could it be Crohn's, could it be a colitis-related stricture, or is it a neoplastic process? Pseudopolyps, dysmotility, anal rectal dysfunction, not uncommon with impaired permeability, and of course, long-term severe inflammation leads to a higher risk for colorectal neoplasia or colon cancer. So once again, early intervention is appropriate in an effort to mitigate against having long-term consequences and sequelae from the unrelenting inflammation that precedes the development of the complications. What do we call remission? Well, if you have ulcerative colitis and Crohn's, they're different remissions. And a clinical remission could be one term where we look at the Crohn's disease activity index or the Harvey-Bradshaw index for Crohn's. For ulcerative colitis, the different scoring systems, the simple colitis activity index, the Lichtenstein score, the Mayo score, a host of things directly. Biologic remission is when you have healing of the mucosa that leads to low CRP, low fecal calprotectin. In ulcerative colitis, a patient-reported outcome of 0 plus endoscopy of 0 to 1. And I alluded to endoscopic remission in the Crohn's disease endoscopic index of severity, or a short form, the SESCD, which is simple to calculate, or the Frostley score based on the Ibsen database where they looked at endoscopic healing. In the ulcerative colitis, the most widely recognized is a Mayo endoscopic score, the score of 0 or 1, suggesting there's healing of the mucosa. And recently, there's been a focus on histologic healing based on the data from ustekinumab, which is able to heal the bowel in patients with ulcerative colitis. And histologic healing is present, and post hoc analyses have looked at other data from other studies demonstrated similar findings. So the concept of treating to target, which I'm going to just breeze over, is very important, as I alluded to. So we go beyond symptomatic improvement of remission, and we use very clearly objective defined outpoints, such as biomarkers, CRP, fecal calprotectin, endoscopy, the Mayo score, the Crohn's healing, the CDEIS, and radiographic, the Maria score, the MRI enterography to see, is the disease acutely inflamed? Is it fibrotic? Has it healed? And this is reiterated in various guidelines. The Crohn's disease guidelines for the ACG, which I was fortunate to be an author on, the ulcerative colitis guidelines led by David Rubin, and the IO-IBD working group, to name several, amongst other international guidelines as well. So these are important concepts that we use in clinical practice on a routine daily basis. And again, the treat to target is you use the initial treatment, you assess the target. That could be the colonic mucosa and ulcerative colitis. You adjust the treatment. So that could be a biologic, say adalimumab. And then you assess the target after making that adjustment. Has that achieved the endpoint which you like and need after the appropriate period of time? If the target is reached, you monitor. If it's not reached, you continue adjusting until you get to that particular endpoint directly. And IOIBD has suggested treating patients for Crohn's, you look at the clinical/PRO remission, patient-reported outcome remission, as was mandated by the FDA in looking at clinical trials. And this would include resolution of abdominal pain and diarrhea, altered bowel habits, and assessment a minimum of 3 months during active disease. Whereas the endoscopic component is resolution of the ulceration. And this is either that or endoscopically or cross-sectional imaging, and most typically at 6-month intervals at the earliest, perhaps 9 months during active phase, to see if you get adequate healing. And this is similarly found in ulcerative colitis. Based on their recommendations, this has become guidelines in clinical practice. The clinical, the PRO, and that's rectal bleeding and diarrhea, and the endoscopic component. You typically look for a Mayo score to improve in ulcerative colitis. So a 0 or 1 would be an outstanding endpoint that one could try to achieve. And if we look at the different clinical trials that have been done, they've been defined in different ways. So the ACT trials, the registration trials for ulcerative colitis, the UC Success trial led by Remo Paniccioni. This is looking at infliximab, azathioprine, or combination therapy, showing again the endpoint Mayo subscore 0-1. The Optiv trials, the Varsity trial, the recent prospective randomized trial that looked at individuals using adalimumab versus vedolizumab in a prospective randomized controlled fashion, or the Serene UC trial, which we'll hear about as well, which is high-dose adalimumab, again, Mayo subscore 0 or 1. So these represent good clinical practice endpoints to look at patients, whether they respond or not. Is there endoscopic mucosal improvement or not? In a similar vein, we look at why we would want to do this directly. And we recognize that the cumulative probability of reaching mucosal healing is escalated in those that have mucosal healing. And you can see this outlined here for Crohn's disease, the article by Bougen et al. Directly. And we look over time, the progression of mucosal healing is higher. In another study as well, we see that individuals, a study by Philippe Bert and Schnitzler and their group, again, the Belgian group under Paul Rutgeert's lead over the years, and Severine Vermeer and Geert de Haans, mucosal healing after therapy predicts the improved outcomes in Crohn's disease. So remission off steroids and off anti-TNF was substantially better. And it's important to recognize the Schnitzler study on the right showed that partial or complete mucosal healing have less risk of major endoscopic or major surgery. So this is an important component. When you look at none, those fared worse. So either partial or complete is an excellent endpoint we strive for in clinical practice. Now, when we look at patients, we look at surrogate markers. We can't do colonoscopies every 2 months in patients. So we look, are they going in the right way? Is the fecal calprotectin staying low? Is the C-reactive protein going down? And is it in a state of low level or normal? And it's the highly sensitive CRP. It's not the cardiac CRP that we look at. And again, recognizing this is not elevated in all patients. The CRP is elevated in about half patients with ulcerative colitis and about 60 to 80% of patients with Crohn's. And if it's elevated, it may serve as a good biomarker to see, is the response occurring? Does it go down over time? ESR and lactoferrin are less widely used. Now, it's important to point out something. There's differences between activity and severity. Activity is what's happening now, and the severity is what's the future hold. Is there a low severity? Is there mild colonic inflammation in patients? Or is there something that suggests high severity? In other words, risk factors for future complications. Early age of diagnosis, upper digestive disease in patients with Crohn's. Smoking and Crohn's worsens the disease. Prior penetrating complications or surgery, in other words, fistulizing disease. Deep ulcers or perianal involvement or portend a poor prognosis. So early aggressive therapy is critical to think of in these patients before the complications ensue. And a high-risk patient is someone who should not be waited upon to say what happens without medical therapy. Aggressive therapeutic intervention is appropriate. And most patients in Crohn's have high severity. If we look at population cohort studies, more than 60% will require intestinal resection over a lifetime. About a third will have moderate disease, and about 10% or 20%, depending on the studies you read, may have mild severity of disease. And the mild severity might be such as a patient you're doing a colonoscopy on, and you peer into the terminal ileum, you see small aphthous ulcers. You follow that patient over time, annually, and perhaps with biomarkers, calprotectin, CRP, and you look to see, do they start to go up, CRP or calprotectin? If they do, it's time to aggressively treat that patient. But if you have a few aphthous ulcers, they may stay the same for years and not go and advance further. So this might be an appropriate person or population to not treat with biologics. Whereas the high severity patient, based on the features discussed, one would start a top down. In other words, aggressive biologic therapy, anti-TNF, anti-integrin, anti-interleukin 12-23 would be appropriate in Crohn's disease. In ulcerative colitis, most patients have low to moderate disease, and that's contradicting its distinction compared to Crohn's disease. There's several risk factors we have for colectomy. The high-risk features are young age of diagnosis. In other words, they have shorter duration of disease, high biomarkers, CRP, calprotectin, and have severe anemia, hemoglobin of 7 at presentation, portends a worse prognosis. Tachycardia, fever, deep ulcers, eosinophils in the mucosa. We presented that data at Digestive Disease Week, and others have seen that eosinophilia as well. Pancreatitis, failure of prior agents. So that's your higher risk patient that needs aggressive initial intervention. So looking at disease overall, we see low risk for colectomy and ulcerative colitis is someone who has limited anatomic extent, mild disease. And the high risk is someone who's younger, extensive disease, deep ulcers, steroid dependency, high risk with a high CRP or a SED rate. C. diff infection portends a higher risk of colectomy and hospitalization, as does CMV. So once again, if found, be careful, watch these patients, observe them, and initiate appropriate therapy at the correct time. Target the initial therapy to the risk status. So the high risk is high maintenance and early intervention, quote, top down, starting early and giving the biologic up front. Monitor frequently, achieve a deep remission, heal the bowel, clinical remission, biologic remission, prevent bowel damage. And an example of top to bottom in the same patient you can see here, some deep ulcerations, completely healed, normal vasculature on the bottom. So again, change the course of disease, modify it. We monitor directly. The goal is to achieve and maintain deep remission. That means endoscopic and histologic healing, and you need more frequent monitoring. Think of the hemoglobin A1C. We do that often every 3 months in patients with diabetes mellitus. It's more frequent and more active and more severe disease to enable you to avoid complications such as fistulas in people with Crohn's disease. So again, be aggressive, be appropriately aggressive based on the severity. In other words, the punishment has to fit the crime is what we always say. So when and how do you monitor? You have the patient who sees you, you're doing proactive assessment of the inflammation. During a flare, one might do every 4 weeks or less. If there's a recent flare or change in therapy and they're doing well, it might be every 3 months. If it's greater than a year of deep remission and they're on a biologic, maybe twice annually. And multiple years of remission, not on a biologic, say they're on mesalamine, might be annually. How do you assess? Well, a CRP is easy to measure, it's cheap. Fecal calprotectin is helpful and can provide assessment of the levels in the stool, but recognizing if a CRP normalizes, you want to trust but verify. Check the bowel, look for mucosal healing, because 20% of patients with normal CRP with Crohn's may have persistent inflammation. And that's important, and MRI enterography is another assessment tool we have. So to summarize for ulcerative colitis, low risk is remission greater than a year versus a flare within a year, stable maintenance therapy, these are the maintenance strategies, endoscopic healing versus persistent endoscopic lesions, histologic healing versus persistent histologic inflammation, and then smoking habits are important. A recent person who stopped smoking has a higher risk of active disease. So these are the higher risk patients. You tell them to start smoking again? Well, some might, but I think that's a little too dangerous, so I personally don't. And good adherence to therapy is very important, with the age being younger for more severe disease. And those that are at high risk monitor more frequently. So here's an example on the right, clinic visit every 3 to 4 months, calprotectin 2 to 3 months, versus on the low risk on the left. And then the CRP and endoscopy if you have symptoms or abnormal findings. So this is an important thing to do in an aggressive fashion. Assess the needs and feedback. The CRP can be noisy. A respiratory infection can cause it to be elevated. C. diff, norovirus, E. coli can cause fecal calprotectin to be elevated, so they're not specific. Rule out infection. Check for enteric pathogens, viruses, C. diff, and look. When you think you have a good overall assessment, look with the scope. Do a flex sig in someone with ulcerative colitis. The AGA pathway for Crohn's initially came and suggested this going back 6 years ago. Again, the low risk, the high risk. Is the age at diagnosis young or old? Is the anatomic disease extent extensive or limited? Is there perianal disease? That portends a worse prognosis. Are they deep ulcers? Again, worse. Prior surgery, the past predicts the future in many patients. And do they have stricturing or penetrating behavior? If the answer is yes to these, then they're high risk, and aggressive early intervention is very important, and document, treat to target. Heal the bowel or nearly heal the bowel based on the data from Schnitzler et al. So the era of precision medicine, we can make a diagnosis, we can risk stratify, and there's some serologic data I'll share with you in the future. Look at endoscopy. Early high-risk intervention is important with biologic, and you might want to use combination therapy, anti-TNF and anti-metabolite, azathioprine, because that gives a better prognosis. The UC Success trial showed that, and the SONIC trial for Crohn's. So combo therapy, it prevents immunogenicity, lowers the RE system activity, gives you a higher drug level and better outcome overall. Over 1 year's use of the anti-metabolite puts you at a little higher risk for lymphoma. So one might consider in the right population stopping this prior to a year if it's medically appropriate. And then a low risk intervention based on the findings. The disease severity I alluded to again, 20 to 30% of Crohn's, but it's 10% in some studies, will have an indolent disease course. Most patients need therapy that controls the inflammation. So up to 80% may be hospitalized. The 10-year risk of surgery is 40 to 55%, and it's decreased now at least 30%. If you look over 10 years, it may be a 10% risk of needing surgery based on some recent population cohort surgeries. And again, look at your comorbid risk factors and your disease-related risk factors to say, are they at a higher risk? And this is highlighted from the American Journal of Gastroenterology, most recent guidelines in 2018 that I had the opportunity to be involved with. Early anti-TNF therapy slows disease progression in Crohn's, and this is one of the many trials that have looked at such, looking at the disease duration. Less than 2 years, 2 to 10 years, greater than 10. The Le Mans index is based upon the severity based on the disease, or the disease duration. And then the timing of the anti-TNF, you can see the Le Mans index changes on the right. So higher is worse. So early intervention does better. tight control, not only with endoscopic, but look at the biomarkers. The CRP, the calprotectin, should be kept at a low or normal levels if it's at all possible, based upon patients' optimization of their therapies they're on. And histology as well has been looked at recently, and I alluded to this in the recent data with ustekinumab. The diseases are mucosal inflammatory disorders, that's Crohn's and ulcerative colitis. Histology is necessary, but not always sufficient for accurate diagnosis. You may have, some controversy. You may have to look again over time and see, does the inflammation persist once you exclude enteric pathogens? The level of inflammation is important. It predicts the time to relapse. So persistent lymphoplasmacytic infiltration of the lamina propria in ulcerative colitis, based on data years ago, Mark Peppercorn and his group presented that in a small cohort of patients, a higher risk of relapse. And severe inflammation is associated with a higher risk of neoplasia. This is the ISBN data I referred to, the Frostley data, showing patients without endoscopic activity at a year that didn't undergo colectomy was less compared to those that had endoscopic activity persist 1 year out after initiation of therapy. And this was before the era of anti-TNF. This is with azathioprine, anti-metabolite therapy. Another study, Christensen showed, again, complete histologic remission. Patients with ulcerative colitis, histologic quiescence and histologic inflammation. And this is the patients in clinical remission. So that's the clinical relapse-free survival at a year, 2 years, 3 years, 4 and 5 years. And you can see those that had complete histologic remission did better overall, but still one can expect maybe 20% of people in remission to flare over the course of time based upon this analysis in a retrospective fashion. Now, histology is important to recognize some of the caveats. The biopsies are thought to be objective. Histologic quiescence is, quote, more stable disease control, and it's more predictive of outcomes than historic markers directly. There's some issues, however. The disease may be patchy. You have to know where to sample. You're only sampling a small surface area of the mucosa, and you need some judgment. So you need an endoscopist who's experienced. In the worst disease, you tend to biopsy the areas that are less involved. In milder disease, you tend to biopsy areas that are more involved. So again, you have to be uniform and know what you're doing. And multiple people and level of expertise have to process and interpret the data that's been assimilated. So the evolving goals for ulcerative colitis management are use deep, deeper, and deepest remission is what we try to achieve. We try to get histologic, endoscopic, and clinical remission, but don't let perfect be the enemy of good. So if you have near complete healing histologically, and you have a patient who has endoscopic mucosal healing, and they're on a biologic, they're on the highest dose, you don't say that patient failed the biologic, you maintain them on that biologic, you follow them over time. If they have disease reflares, then consider a different biologic. But if they're not optimized and you have persistent inflammation, you can optimize that biologic based upon current consensus, though there's no controlled data assessing this. The high risk, the not so high risk, you follow, you risk stratify, you do different imaging studies different times, but you monitor the high risk more frequently than the not so high risk directly. As you can see here, as an example over time, what you might do in these patients. The MRI enterography, and this is an example of the Maria score that has been looked at. And again, ulcer healing is a pretty good negative predictive value, and the accuracy about 90%. So it's reasonable to use in clinical practice. Point of care monitoring. This is going to be something coming to fruition. Daily fecal calprotectin, CRP in hospitals. It's radiation-free, no prep, and low cost. Monitoring calprotectin at home. This is now coming to fruition. In the European communities, this is available, not yet in the US, but I foresee this in the future, so you can check that. Telemedicine in the era of COVID, this has come about. We can monitor patients better. They can communicate with us, and we can see them virtually in a very rapid fashion. In the same day they call, say, I'm having trouble. as opposed to coming in, you can immediately see them in a virtual visit. Fewer hospital admissions overall, best care. And then we're going away from how do you feel to complex models. This is illustrated by a study Corey Siebel published several years back. So once again, optimization of therapy with evidence. And we have predictors of response that'll be forthcoming. So who should we use these in? Oncostatin M has been a predictor in infliximab. It's now undergoing validation. Serum IL-22 in IL-23 antagonists. The microbiome, Ashwin and Anthrakrishnan published data showing you can predict vedolizumab. And then others are forthcoming looking at these directly that require prospective validation. And again, the partial mucosal healing, remember, is very good to achieve. And if you have 3 active ulcers left and someone had severe colonic Crohn's in nearly all over, this is an outstanding response, and don't push to get better healing if you have to switch agents. If you have that, follow that patient, and that's nearly as good as complete mucosal healing. So I've gone through a whirlwind tour, and hopefully this has given you an overview as to how to practice. The goals of treatment have evolved. We now control disease itself, not just symptoms. We want to stop damage, prevent the disability in the bowel that may come about. Tight control, like rheumatoid arthritis, diabetes mellitus. It produces better outcomes. Choose aggressive therapy based on the disease course, the disease activity, and monitor based on the clinical scenario and the patient prognosis overall, and try to achieve the appropriate target. Thank you.
Good afternoon. I'm Dr. Steve Hanauer from Northwestern University here in Chicago. I'm sorry that I'm not able to attend in person to the GALA Tri-State Conference, but I hope you enjoy this combination of in-person and virtual presentations. I'm going to be speaking on practical applications of the treat-to-target strategies in inflammatory bowel disease, which is obviously one of the more important current thought processes that are really changing our approach to patients with ulcerative colitis and Crohn's disease. I'm beginning with the concept of separating disease activity from disease severity. And why do we start here? We start here because the indications for many of our therapeutics, in particular the biologics, are for moderate to severe IBD activity in patients who have failed conventional treatments. So that sentence and the labeling includes both activity and severity. And a group of international thought leaders has begun to dissect this concept into what do we really mean by activity and what do we really mean by severity. Activity reflects the cross-sectional assessment of the impact of the disease on a composite of signs and symptoms, endoscopy, and biomarkers. Whereas severity really implies prognosis, or the long-term course, or the risk of developing hospitalization, surgery, or other complications of the disease. And we can see how these are separate because activity refers to how is your patient today? And as reflects the clinical trials, these are essentially the entry criteria, the symptoms and the endoscopic activity that allow patients to enter a trial for moderate to severe disease. Whereas severity pertains more to the likelihood of the disease progressing, or essentially prognosis over time. Now, along these lines, our societies have begun to risk stratify patients with ulcerative colitis based on the prognostic risks of them. For ulcerative colitis at presentation, individuals who have extensive disease, deep ulcerations, are younger, have elevated biomarkers, require steroids from the onset or hospitalization, or of complications such as C. difficile or CMV. They're very similar in Crohn's disease. The risk for progression to transmural complications and the need for surgery or hospitalization also include young age at diagnosis, the extent of anatomic involvement. Patients who have ileal disease are at greater risk for needing surgery, and patients who actually present with complications such as perianal disease or severe rectal disease, and again, deep ulcers in both Crohn's and UC portend a poor prognosis. So our concept of treating to target goes beyond the concept of treating the symptoms the day the patient is presenting to go on to treat the factors associated with an improved prognosis, or how to reduce the likelihood of colectomy in ulcerative colitis, cancer in ulcerative colitis, hospitalizations and surgery and resections in patients with Crohn's disease. And this concept of treating to target is really to prevent the complications. The analogy I give all the time to my patients is hypertension. We don't know the cause or have a cure for hypertension. We have a variety of different medications. We know that patients with hypertension are at risk for strokes and heart attacks, but by monitoring the blood pressure, achieving therapeutic targets of 140 over 90, reduce those long-term risks of complications from the disease, even though it's not curable and even though we don't stop medications for hypertension. Now, when considering the targets, they have evolved over time. We've learned that improving symptoms and clinical remissions improve the quality of life for patients. We also have the concept of a steroid-free remission to reduce the complications of concomitant therapy. But we've learned that when we treat to deeper indications, such as mucosal healing, histologic improvement, there we can begin to change the course of the disease and improve the long-term outcome. So our definitions of remission per se have actually evolved as well. And they include defining clinical remission based on symptom scores, steroid-free remission, which is achieving symptom scores of remission with elimination of steroids, or a deeper biologic remission that includes improvement in inflammatory symptoms, as well as reduction in biomarkers such as CRP or calprotectin. We've learned that both in ulcerative colitis and Crohn's disease, achieving endoscopic remissions, either according to the Mayo score in ulcerative colitis or the simple endoscopic score in Crohn's disease, also improve outcomes. And we are just learning how to incorporate histologic remission into this paradigm of achieving target improvement. First and foremost, we have learned that symptoms are not a reliable indicator of mucosal healing or of long-term outcomes. And just a simple example from the ulcerative colitis ACT studies with infliximab demonstrate differences in both clinical scores, patient remissions, and mucosal healing. They don't line up exactly in line such that the same person who has endoscopic healing has clinical healing. And we know this from our own practice. We see a discrepancy in our surveillance colonoscopies of patients who feel well but have active disease. And conversely, we see other people who feel sick but don't have any disease activity. And that emphasizes these discrepant findings. Nevertheless, we've learned from a variety of observational series and post hoc analyses that patients who achieve endoscopic improvement have a better outcome. And in this case observational series from Scandinavia that's now over 10 years old, the proportion of patients who achieve endoscopic healing have a far less risk of requiring colectomy in the first 10 years of the disease. Similarly, in Crohn's disease, patients who have improvement or resolution in endoscopic ulcerations based on the simple endoscopic score have a lower risk of major abdominal surgeries. So in both ulcerative colitis and Crohn's disease, we have evidence that endoscopic improvement can lead to improved outcomes. Now, obviously, these are inflammatory diseases, and we do have the ability to demonstrate inflammation histologically, which is obviously undermining endoscopic disease activity. But thus far, it's been a challenge to come up with reliable and validated histologic indices in both ulcerative colitis and Crohn's disease. Nevertheless, in post hoc studies, we've learned that reducing inflammation has been associated with clinical endpoints such as time to relapse, as well as the risk of neoplasia in ulcerative colitis. Most recently, in a study with ustekinumab in ulcerative colitis, investigators combined both endoscopy and histology into a combined endpoint, essentially histoendoscopic mucosal healing, that combines these very important endpoints that have been predictive of longer-term outcomes. Indeed, this still remains somewhat challenging because we are aware that there is still some patchiness, certainly in Crohn's disease, which is a focal disease, but also in ulcerative colitis. All segments of the colon do not necessarily heal at exactly the same rate. We also know that our biopsies are only representing a small area of surface of the mucosa. And there's probably some bias in how we're actually sampling for histologic and pathologic analyses. Whether we are biopsying the worst areas or milder or normal areas to make the patient look better or worse. So most recently, histopathology has also undergone central reading that has improved the reliability of the histologic assessments. So moving forward, our international organization, the IOIBD, has recommended treating targets for treatment in both ulcerative colitis and Crohn's disease that include both clinical, which is a patient-reported outcome, and in ulcerative colitis, that is resolution of rectal bleeding and diarrhea, as well as endoscopic resolution of friability and ulceration at flexible sigmoidoscopy after the initiation of any therapy. So just as with blood pressure, we would treat patients with the drug and then have them come back and recheck the blood pressure. In ulcerative colitis, after initiating a therapy, we know that everybody doesn't improve at the same rate. So after 3 to 6 months, we want to observe their symptoms as well as their endoscopic activity. The AGA has developed a clinical pathway for ulcerative colitis and Crohn's disease that we've discussed extensively, that at first separate patients for low risk of colectomy. These are the ones who have a good prognosis compared to those features associated with more moderate to severe outcomes of the patients with a poor prognosis. In the setting of Crohn's disease, the IOIBD has also divided the outcomes or the targets into both clinical and endoscopic. And I should mention, moving forward, there will be an evolution to include histology into the outcome, but we're not quite there yet. In Crohn's disease, the clinical criteria are abdominal pain and diarrhea, and endoscopy also includes either colonoscopy, obviously endoscopy, or if we have an inability to observe areas proximal to the extent of colonoscopy, the addition of imaging studies. Now, I'm not going to discuss imaging because this is another endpoint that is also challenging and is not quite right or not quite ready for immediate use. Once we initiate therapy, we can assess patients after 3 months again, but as we know, some agents may take 3 to 6 months to achieve a full operational effect. And endoscopy in Crohn's disease takes even longer to improve than in ulcerative colitis. And frankly, I don't even look at patients who've had deep ulcers until at least 6 and usually 12 months after initiating a therapy. And again, the AGA has divided patients according to good prognosis or poor prognosis and assigned therapeutic pathways for those individuals who then should be reassessed in our treat to target strategy. Now, there is one setting in Crohn's disease that is different than ulcerative colitis. And that is in Crohn's disease, more like rheumatoid arthritis, there is less structural damage early on. And prevention of structural damage is a goal in Crohn's disease. But what if they already have structural damage? As if it was a patient with rheumatoid arthritis who already had structural damage and joint deformity. There's no therapy that's going to make those joints straight again. So in that setting of ongoing structural damage when we're initiating therapy, we can't expect to reverse a stricture in Crohn's disease. What we can do is reduce the inflammation around the stricture that may be causing the symptoms or contributing to the symptoms. So in later disease, we're not always going to be able to achieve the same target as in early disease. So the practical question is, when and how do we do this? Well, we begin with the proactive assessment of the severity. In patients who are flaring, we're not going to wait 3 to 6 months to assess them. Sicker patients are going to be evaluated weekly or even in the hospital on a daily basis until their disease stabilizes. And then we can continue the monitoring pattern. And as I mentioned, in Crohn's disease, I won't even look at an endoscopy until 12 months afterwards. We then assess for a deep remission, and this is also impacted on outcomes because we know that in patients, for instance, on combination therapy, that if they achieve clinical, endoscopic, and biomarker resolution, we are able to discontinue either the biologic or the immune modifier and continue with monotherapy in those individuals rather than combination therapy. And then there are going to be a few patients who've really had a long-term remission. And everybody with ulcerative colitis who's been in clinical and endoscopic and histologic remission doesn't need yearly colonoscopies. If we've achieved our goals, we can then delay them out to 2 and sometimes even 3 years. As far as biomarkers are concerned, C-reactive protein is very accessible to us, and fecal calprotectin can be useful, although it's a challenge in patients who have left the clinic to get them to submit samples back in. And as I've already emphasized, we're not quite ready to invoke imaging criteria, such as the Maria score using MRIs, which require better and ongoing validation and reproducibility and education to our radiologic colleagues who are going to have to conform to our way of measurement. Now, there have been examples of how this treat to target strategy has been employed in a clinical trial and demonstrates overall improvement. In what's known as the CALM study, patients with Crohn's disease were randomized to receive either a symptom-driven therapy versus a biomarker therapy that includes both symptoms as well as calprotectin and C-reactive protein. Patients were escalated to achieve their targets in one or the other therapeutic arm. Patients were randomized early if they had had a steroid therapy greater than 4 weeks, then they could be tapered according to the investigator. But patients were also allowed to go through a rescue therapy and disease escalation if they were not improving according to either symptoms or biomarkers. If you look at the left side of this panel, the endoscopic score, according to the Crohn's disease endoscopic index of severity, was markedly improved in the patients who were treated according to symptoms and biomarkers, with either allowing an escalation in therapy compared to the patients who were escalated by symptoms, who also had more symptom improvement, but no improvement or lesser improvement as far as endoscopic scores are concerned. Now, our IOIBD is evolving this strategy, and in a subsequent publication, we're going to see an evolution of this treat to target strategy in both ulcerative colitis and in Crohn's disease. It's going to include the same risk assessment, assessing symptoms and biomarkers to achieve as great a degree of healing as possible, but also will be including histologic criteria that have been associated with reduction in flare-ups, as well as a lower risk of colon cancer. In Crohn's disease, similarly, improvement in symptoms and biomarkers are going to be a short-term goal, which includes normalization and endoscopic healing, if possible. And again, the problem with Crohn's disease with histology is the focality of the disease and the need to improve our reliability of histologic sampling. But I want to conclude with the biggest risk of all. And the biggest risk is inadequate treatment, letting patients remain symptomatic or with ongoing disease activity who have not achieved their therapeutic targets. These are going to include flare-ups, hospitalization, escalation of medications, risks of colectomy and surgery in ulcerative colitis and Crohn's disease, the risk of cancer, in particular with ulcerative colitis, and we're increasingly aware of the risk of cardiovascular disease related to ongoing inflammation. So I hope in this short time that I've contributed to your understanding of the rationale for developing therapeutic targets beyond symptoms, that we can now define and work to achieving those targets, evidence that when we do so, we can improve clinical outcomes. And finally, as this slide implies, the worst situation is uncontrolled disease with the risks of both decreased quality of life, pharmacoeconomic costs and hospitalizations in surgery, and worsening comorbidities, including cancer and the risk for cardiovascular disease. So I hope this has been helpful, and I certainly hope you enjoy the rest of this year's gala, and we look forward to next year's program. Thank you.
Good afternoon. I'm Dr. David Binion from the University of Pittsburgh and UPMC Presbyterian Hospital, and I'd like to thank the organizers of the GALA Symposium for the opportunity to give this presentation on, I think, a really important area in the management of our patients with Crohn's disease, which is really the interplay of surgery and medical management. And we're going to focus on managing post-operative Crohn's disease in this section of our symposium. I do have some disclosures which are listed here. So the overview of this presentation is going to focus on a series of issues with Crohn's disease. We're going to touch on the natural history of Crohn's disease and how important surgical intervention is. And this really speaks to the severity of our patients with Crohn's. I think we all are pretty comfortable with the idea that Crohn's is not a one-size-fits-all disease. We have individuals with mild, medium strength, or moderate disease, and unfortunately some individuals with more severe disease who do face multiple surgical procedures, and that's going to be the cohort we think about during this presentation. We're going to talk about how Crohn's disease recurs after surgery and how we can best assess this. And we're going to talk about who are the individuals who are perhaps most at risk of having significant recurrence and facing repeat operations in their lifetime. We're going to talk about new advances and new insights that have come forward in how we might be able to prevent Crohn's disease recurrence after surgery, and how in some regards this may be our best opportunity to effectively use our medical therapies. We're going to talk about, we're specifically going to focus on some of our traditional approaches with antibiotics, azathioprine, and newer insights when it comes to biologic post-operative prevention. And then we're going to wrap up this section of the conference by talking about post-operative symptoms that may not be related to inflammation. And we're going to share some new insights regarding the types of surgeries and how this might impact the functional status of our patients. We're going to put a little bit of emphasis on something that I think doesn't get enough attention, which is treating bile acid diarrhea, bile malabsorption in our patients in the post-operative time period. So we're going to start at the beginning of the Crohn's disease saga back 9 decades ago in 1932. The original paper describing Crohn's disease was a cohort of 14 individuals who had just had surgery, and the surgical tissue had granulomas, but no mycobacterium. And what we see here on these two Frank Netter illustrations are really the natural history of how Crohn's disease will progress and fibrose. And what we're looking at here is the end-stage fibrotic complication of Crohn's, what was seen in that original description back in 1932, where the lumen of the small bowel has been obliterated. And now, unfortunately, fistulizing complications have occurred into adjacent loops of bowel and the bladder. And in the past era, the goal of surgery was to relieve obstruction. Patients who are suffering this level of complication are basically in a very desperate situation. They have essentially an intermittent partial small bowel obstruction occurring regularly, and the body's trying to solve this by fistulizing. Back in past era, we didn't have the medical options that we have today, and steroids were our most important medical tool, but they come with a high price tag. So surgery was the goals were to relieve obstruction, to discontinue our best agent back at that time, steroids. And fibrotic disease is really too late. It's not going to be responsive to medical therapy. We do have new insights when we think about Crohn's disease at the present era. And this illustration really highlights the idea that Crohn's begins as an inflammatory process. And over the course of time, that time might be faster in some individuals, slower in others. There's a progression to fibrosis and the luminal damage that we're seeing above. So if we think about new concepts in the management of Crohn's, we're going to use immunomodulators and biologics to control Crohn's disease inflammation. And early inflammatory disease is definitely the most responsive to medical therapy. However, we don't have the luxury of reversing time in our patients. So in some regards, surgery gives us an opportunity to have a second chance. It gives us a second chance to treat early disease because we know exactly when Crohn's is going to recur on the day of that operation and when people start to eat again in the post-operative time period. And we've come to realize that post-operative Crohn's disease is extremely responsive to medical therapy. So again, if we think about the natural history of Crohn's disease, the vast majority of patients face an operation in their lifetime. And here's some older data from North America and Europe suggesting up to 80% of Crohn's patients would face a surgical intervention. And we know which patients are going to have the highest risk for surgery. It's people with small bowel disease and particularly ileocolonic disease. And on this barium study on the right, we see the classic string sign where there has been obliteration of the lumen. And this is a person who has few options left if they're experiencing obstructive symptoms. Again, when we think about the natural history of Crohn's disease, there's some excellent data that comes to us from our colleagues in Copenhagen County, Denmark, from Pia Munkholm's group. And this represents a population-based cohort of Crohn's patients who've been followed from the time of diagnosis. We're going to focus on the 15-year time period. And what we see here is about a third of the patients have not needed an operation at 15 years following their diagnosis. Approximately a third of the patients have had one surgery, and approximately a third of the patients have gone on to have multiple operations. So I would argue this is essentially mild, medium strength, and more severe disease. And I think that we would all agree that the goal is to identify the third of patients who face multiple surgeries in their lifetime. And these are the patients who will have the biggest benefit from post-operative chemoprevention strategies. So if we can identify the half of patients after surgery who are going to need more aggressive medical strategies, implement those strategies quickly and effectively, we're going to hopefully have an impact on this natural history. And the unfortunate reality is about a fifth of the Crohn's patients have 3 or more surgeries, the sickest of the sick. When we think about some of these incredibly sick patients, we did a study a number of years ago looking at what we called rapid abdominal reoperation for Crohn's disease. Surgery is the fastest way to induce remission in a Crohn's disease patient, and we fully expect that patient to stay in remission for some time. But in our tertiary referral cohort, we found that 7% of our Crohn's patients required a repeat operation within 2 years of a prior surgery. When we started to dive into what were the clinical factors associated with rapid abdominal reoperation, we found that 2/3 of these patients were not on medical therapy. This might have been the result of limited options when we did this study a few years ago. And I think the other driving factor was the fact that some of the gastroenterologists were waiting for those patients to complain. They were waiting for them to give a clinical evidence of getting worse with their Crohn's activity. And 2/3 of these individuals were not on immunosuppressive or biologic therapy after surgery. And I would say that maintenance medical therapy is mandatory for this type of a severe Crohn's disease cohort. Anyone who tells you they've had surgery within 2 years of an operation is someone who has earned the right to be on some of our best medical options. And what we'd like to do is prevent what we're seeing in this barium study, which is short bowel, in a person who's developing a stricture at that ileocolonic anastomosis. So how quickly does Crohn's disease recur after resection and reanastomosis? So this is really the key question. How do you define Crohn's recurrence? So it turns out that we have a number of ways to do this. Histology, looking at biopsies from endoscopic data, is going to be our most sensitive strategy. Endoscopy is very good. It's a very excellent strategy to do things. But if we wait for our patients to complain about Crohn's disease recurrence, that's actually our least sensitive strategy. And that might have been what got some of our rapid abdominal reoperation patients into deep trouble. So this is a study that was done by Geertjans over 2 decades ago, which is one of the most insightful studies that we've ever had regarding the etiopathogenesis of Crohn's and how it comes back after surgery. And what Dr. Dans did in this study was basically explore how luminal contents, basically when we're eating, we actually will support the growth of bacteria in our GI tract. There is breakdown of food, there's bile coming through the GI tract. And in a cohort of patients who had a diverting ostomy above an anastomosis, he basically took some of the luminal content from the ostomy, infused it into the downstream limb of the double-barreled loop ileostomy, and was able to do endoscopy on that segment. And he found that the remission after surgery would show evidence of recurrence histologically within 1 week of reinfusion of luminal contents. So this was an incredibly insightful observation that the luminal contents, the bacteria, the microbiome, the digestate, is going to be driving inflammation in our Crohn's patients. So when we think about the natural history of Crohn's disease, histologic evidence of recurrence can be as fast as a week. Endoscopic evidence of recurrence can be seen in over 70% of our patients, typically by a year. But when we wait for more advanced evidence with either radiologic, clinical studies, it may be too late, and that's going to lead to surgical recurrence in many of our individuals. So can we predict the postoperative course of Crohn's disease? I would argue yes. And I would say that histology, simply reading the pathologic information from the surgical specimen, gives us an incredible opportunity to stratify our patients in terms of who will be at higher risk to have more aggressive recurrence in the postoperative time period. We did this study where we looked at over 1,400 patients with Crohn's to see who had granulomas, the hallmark feature we talked about in the very beginning that was identified in the Crohn's patients back at Mount Sinai Hospital in 1932. And we found that endoscopic evidence of granulomas occurred in about 13% of our patients. When we looked at surgery, it was about 21% of our Crohn's patients who had surgery had granulomas on their surgical resection material. And those individuals with granulomas had a more aggressive disease course in the years that followed surgery. What we have here is the Lamont Index, which is a new way to stratify damage in our patients. And we're seeing that individuals with granulomas had worsening of disease over a 5-year time period. But when we look specifically at the postoperative time period in a cohort of 600 Crohn's disease patients, 21% of whom had granulomas, we found that at a 6-year postoperative time period, half of those individuals, 50% of people with granulomas, had to have repeat surgery, which was double the rate that was seen in patients with Crohn's who had surgery with no granuloma seen on the histology. So simply reading the pathology report after surgery gives us an important insight in terms of who will be higher risk to develop this more aggressive recurrence. One of our more standard approaches to looking at postoperative recurrence uses endoscopy. And this is the Rutgers score that you've oftentimes heard about in the past several years. So Paul Rutgers, who unfortunately passed away just this last month, was one of the giants in inflammatory bowel disease investigation. And he published this study 3 decades ago from his group in Leuven, Belgium, where they basically followed patients postoperatively. And this was an era where there was no standard strategies for medical prevention. And they came up with an endoscopic scoring system, the Rutgers score, that would then allow us to stratify our patients going forward. And basically, when patients either had a normal neoterminal ileum or small aphthous ulcers that were just rare, an isolated ulcer, maybe 2 ulcers, in the endoscopic assessment of the neo-TI 1 year after surgery, those individuals had an incredibly benign clinical course moving forward. If an individual had more aphthous ulcers, this is 5 or more ulcers identified in the neo-TI. This is a Rutgers I2 score. This individual had approximately a 40% chance of clinical recurrence by 6 years. If there were bigger ulcers 1 year after the surgery, stellate ulcers, there was going to be a much more rapid progression. So at the 6-year time period, 80% of those individuals would have had clinical recurrence. And then the most impressive score, the Rutgers I4 score, many of those individuals didn't even make it to the full year. And this was a very rapid ulceration identified at the neo-TI. So if we assess our patients at that 1 year time period, it gives us important prognostic information about where they're headed into the years going forward. So the Rutgers score demonstrates recurrence at the neo-TI. It's not only an endoscopic score, but it's a predictor for future complications, and it predicts the severity of that patient moving forward. So how does Crohn's disease medication therapy influence endoscopic recurrence following surgery? So when my colleague, Dr. Miguel Reguero from the Cleveland Clinic now, but when we worked together at the University of Pittsburgh Medical Center, actually explored this with this meta-analysis that we're looking at here. So when we think about postoperative prevention, endoscopic recurrence is more sensitive than clinical recurrence. And when we think about the impact of drug therapy, we can compare it against placebo. So endoscopic recurrence, the majority of patients are going to have endoscopic recurrence at the 1 year time period if they're not on medical therapy. Clinical recurrence lags behind. If we think about the impact of drug therapy, the 5-ASA and budesonide strategies are not particularly different from placebo, but we do start to see a difference when we think about the use of immunomodulators with purine analogs. So there is a separation. And this was explored in a clinical trial that was published in Gastroenterology over a decade ago, where we do see a separation in postoperative patients who've been treated with initially antibiotic therapy and then azathioprine at the 1-year time period. And there's a delta of about 25% in the azathioprine treated group, where a majority of patients are in remission postoperatively, while placebo patients, the vast majority have had recurrence endoscopically. So if we think about biologic agents, specifically the anti-TNF agents and their impact on endoscopic recurrence rates in our Crohn's disease patients, we do have some pretty interesting and intriguing data that has emerged again over this past decade. Again, my colleague, Dr. Ruggiero, did this study a number of years ago, a pilot study that looked at infliximab randomization postoperatively in a cohort of patients with Crohn's disease following ileocecal resection. And at the 1-year time point, he found that endoscopic evidence of remission was clearly more prevalent in the patients who were on infliximab, who were randomized to infliximab infusions, compared to those who were on placebo. If we look at the raw data here, we see that having either a normal or minimal inflammation recurrence at the 1-year time period was clearly associated with infliximab, while patients who were randomized to placebo had significantly more aggressive endoscopic assessment. When we think about the patterns of recurrence, clinical recurrence, again, is not as reliable. So clinical remission was seen in both the placebo and the infliximab group. So again, we're seeing the separation of objective data from endoscopy and subjective data when we wait for our patients to complain. So when we think about the observational experience with the use of anti-TNFs in the postoperative time period, we have a pretty clear signal that up to 10% of the patients on an anti-TNF may experience recurrence, and it's significantly higher in patients who have either been on placebo agents, 5-ASA agents. Again, it might be 40% of our patients receiving purine analog prophylaxis. And these, the weight of evidence that was amassing from these observational studies ultimately led to a registry trial for infliximab in the postoperative time period. Now, the PREVENT trial was in some regards disappointing because clinical separation at the 18-month and 2-year time period did not occur. And what we're seeing here on the left side of the slide is not a clear separation between the two groups. And the trial was stopped prematurely because it didn't meet its efficacy mark in the preliminary analysis. But when we think about the endoscopic assessment of our patients, again, there was a clear separation between those individuals receiving the anti-TNF and those who were receiving placebo. So objective data clearly shows a difference between patients on biologic therapy postoperatively and those patients who were on placebo. And this really begs the question, what are the additional factors that are driving symptoms in our postoperative patients? If we don't see symptoms directly related to inflammation, are there factors perhaps related to the surgery itself or some of the altered physiology? So we're going to explore that in this section, the postoperative Crohn's patient's symptoms related to surgically altered in physiology and not just inflammation. So the majority of our Crohn's patients require surgery. Ileocecal resection is definitely the most common procedure, and there are a variety of strategies that surgeons can use to reconstruct the bowel. But when I go to the endoscopy lab, I have one choice when I'm going to be writing up my procedure notes in my postoperative patients, and this is the one diagram that's available from the Privation software. So I'd ask the question, is this the operation that your patient's actually receiving? What we see in this diagram is an end-to-end, probably hand-sewn anastomosis. But there are a variety of strategies that can be used by surgeons to rebuild the bowel. So it's important to be able to identify these endoscopically and understand how this could be playing an impact on our patient's management going forward after surgery. So we have 3 of the more common anastomoses shown here. Left is the end-to-end hand-sewn anastomosis. Technically, it's a little bit more challenging to do this because the surgeon has to make a smaller tube, the ileum, fit onto a larger tube, the colon. and oftentimes involves spatulation, kind of angling the anastomosis a little bit so the two lumens are about the same size. It takes about 20 to 30 minutes for a surgeon to typically build this type of an anastomosis. In the middle of the diagram, we have an end-to-side anastomosis. Again, it's a surgically stapled anastomosis. This is a more common anastomosis in the United States. And then on the right side of the slide is the stapled side-to-side antiperistaltic anastomosis, which is perhaps the most common anastomosis done in the US at the present time. Again, we'll talk a little bit more about the implications of these in a second, but being able to identify endoscopically when we're working with our patients is an important consideration. So the side-to-side anastomosis, which was done in over half of the patients in the PREVENT trial, reconstructs the longitudinal segments of ileum and ascending colon. And it's a fairly rapid solution for two different lumens of bowel. What we have here in this nice diagram really illustrates this, but endoscopically, what we're going to see is the ascending colon on the top, and that's the blind end that we're seeing here on the diagram. We're seeing this blind end of terminal ileum here on the bottom. And the proximal intestine is actually here behind you. So the endoscope has to make an umbrella hook to actually get into the more proximal bowel. If we were to do the colonoscopy under fluoroscopic guidance, you would actually see this umbrella hook in the colonoscope in order to intubate the proximal intestine. We can contrast this anatomic reconstruction with the end-to-end anastomosis, which is, again, putting the bowel back together as a simple tube. And endoscopically will come across the colon into the neoterminal ileum. This is definitely the easiest anastomosis in terms of gastroenterology, being able to survey the postoperative anatomy as opposed to the anastomosis where we have to make that umbrella hook to get into the neo-TI. So the compression stapled anastomosis, the side-to-side stapled anastomosis, was actually developed by trauma surgeons in the Soviet Union back in the 1950s. Here's a GIA green load linear stapling device. Basically, it has two cutting blades and two titanium rows of staples will be rapidly deployed. It takes seconds to essentially put things together. And the advantage is in the context of trauma surgery, speed. We have an hour to save the life of someone who perhaps was going through blunt abdominal trauma, penetrating trauma. And when we think about MASH units and trauma surgery, this type of an anastomosis is an incredible advantage. We can put a big tube and a small tube next to each other, side to side, deploy the stapler, and then we can close that anastomosis with a perpendicular staple line. These devices were brought to the United States back in 1957 by Dr. Mark Ravitch when he had permission to travel to the Soviet Union. He actually smuggled out one of these devices and then was able to take this technology and develop surgical stapling devices here in the United States. And this became really the genesis of stapled anastomoses in America. So we had some concerns about the long-term appearance of the side-to-side anastomosis because it does transect circular muscle layers and it has an antiperistaltic orientation. And we were wondering if this might have impacts on postoperative physiology. We were concerned that bowel dilatation at the surgical anastomosis highlighted here on this coronal reformat. We can see the metal on the CT scan that highlights this area of fecalization in the intestine. And then there can be distension at the anastomosis, and nociceptors in the bowel can feel distension as pain. And this wide open connection that is happening, that's actually acting as a reservoir, can contribute to small bowel bacterial overgrowth. And we were concerned that this might be disrupting intestinal function over time. So we explored this with a clinical study at our institution that was published 2 years ago in the American Journal of Gastroenterology, where we basically looked at our Crohn's patients undergoing their first or second surgery for Crohn's disease at the ileocecal area. And we wanted to look at the 2-year Crohn's disease related healthcare utilization, which would include emergency department visits, hospitalization, surgery. We wanted to look at the quality of life of our patients over time. And the secondary outcomes were going to be endoscopic recurrence, the objective markers of inflammation with CRP, and the disease activity index. And what we found at that 2-year time period was that there was a significant difference between the patients who had the end-to-end anastomosis, 68 of our individuals in this again, pragmatic study, prospective pragmatic study versus the 60 patients who had side-to-side anastomosis. So there was essentially a doubling of ER visits, 15% versus 33% at the 2-year time period. 12% of our patients with an end-to-end were hospitalized in that post-operative time period, compared with 30% of our side-to-side patients. And when we think about some of our diagnostic strategies, CT scans were required in just over 13% of our patients with the end-to-end anastomosis versus 50% of our patients with the side-to-side. And I would argue that CT scans of the abdomen and pelvis in a Crohn's patient are usually done to assess abdominal pain and abdominal symptoms. When we look at quality of life scores at that 2-year time period, we use the SIBDQ, a published version that goes from a lowest score of 10 to a perfect score of 70. And when the mean score is above 50, that patient is typically doing well. When the mean score is below 50, that actually is a fairly good marker of a person who's having challenges on a regular basis. So the SIBDQ, the quality of life score, was significantly higher and better in our patients with the end-to-end surgery compared to those with the side-to-side. The objective markers of inflammation, either endoscopic assessment or the disease activity or C-reactive protein scores, were not significantly different. When we did a multivariate logistic regression, we actually found that there was a tripling of a risk for being hospitalized in the patients with the side-to-side anastomosis compared to those with the end-to-end. And interestingly, when patients were assessed for post-operative prophylaxis, those individuals who were going on to biologic therapy, it did not make a significant difference in this observational study. I would suspect that this may have been a contributing reason in the difficulties experienced in the PREVENT trial, where we did not control for the surgical anastomosis. And what we suspect might have happened is that the clinical status of patients with the side-to-side anastomosis was perhaps outweighing the clinical readout from inflammation recurrence. When we looked at healthcare economic issues in our patients with end-to-end versus side-to-side anastomosis, we found that the side-to-side antiperistaltic anastomosis was over twice as expensive regarding healthcare charges per patient in the 2 years following the surgery. So I would, again, want to highlight the concept of bile acid diarrhea, bile acid malabsorption, which is something that definitely will occur in patients who experience a terminal ileal resection. It's a very common complication of surgery. And we have a number of agents that can be employed at this time to help with bile acid malabsorption. We have the older compound cholestyramine powder, and then the pill formulations of cholestyramine and cholecylamine. When we looked at our UPMC IBD registry, which tracks over 4,000 IBD patients over the past decade, we found that patients who had had a TI resection who were not receiving a bile acid sequestrant were significantly higher to have higher risk for having abdominal pain and requiring narcotics in a 4-year time period. And when we looked at the use of bile acid sequestrants in our cohort of patients who had had ileocecal resection, we found that the side-to-side anastomosis patients had a harder time tolerating and benefiting from bile acid sequestrant therapy, whereas a little over 50% were able to use these agents with benefit over time, compared to over 75% of our patients with the end-to-end anastomosis. So I would argue that when we think about surgical anastomosis, we can perhaps better treat the complication of bile acid malabsorption in patients who would have the end-to-end surgery reconstruction versus the side-to-side surgery. So the AGA has issued guideline statements on strategies for managing our patients in the post-operative time period. And the AGA's guideline document that was again published 3 years ago suggests that there is good rationale to use pharmacologic prophylaxis in our patients with Crohn's disease. And this was a conditional recommendation. It suggested the choice of agents should emphasize either immunomodulators with purine analogs or anti-TNF therapy based on the existing data. For patients who are not going to have post-operative therapy, it encouraged the use of endoscopic surveillance, the use of an objective assessment of our patients to again guide therapy, and not waiting for clinical symptom recurrence, which is perhaps less reflective of the inflammation at the neoterminal ileum. So to summarize, in the management of postoperative Crohn's disease, surgery is needed in the majority of our Crohn's patients at some point in their lifetime. Postoperative Crohn's disease may represent the ideal time to initiate medical treatment to prevent recurrence of severe disease. We're treating the earliest disease that we have been able to identify, which recurs within weeks of the patient resuming a diet and the microbiome being reestablished in the gut. Some of the higher risk patients will have granulomas on surgical histology and evidence of early endoscopic recurrence at the anastomosis using the Rutgers scoring system, which we highlighted previously. Starting treatment 2 to 4 weeks postoperatively in high-risk individuals who have had multiple prior surgeries, perhaps downstream evidence of inflammation that will definitely be active in the postoperative time period. Individuals with granulomas is definitely a high consideration. And for those individuals where we would prefer to use a watchful waiting approach, we can definitely use endoscopic assessment in the postoperative time period to guide management. I would say that postoperative symptoms can be related to the surgically altered anatomy in our patients who've had surgery and reconstruction. And the side-to-side anastomosis patients are predisposed to develop functional symptoms due to perhaps the antiperistaltic reconstruction, the transection of the circular muscle layers, sort of the reservoir forming anastomosis, which can stretch and in some individuals lead to pain issues, compared to individuals who have the end-to-end surgical anastomosis, where the intestine is more or less reconstructed as a tube. And then lastly, bile acid diarrhea and bile acid malabsorption is an easily treated complication using bile acid sequestrants. And the 3 agents that I've outlined here, cholestyramine powder, cholestyramine, and cholecycline, can function in our patients very effectively. And perhaps ideal dosing is going to be in the morning prior to breakfast. Thank you so much for your attention.
Itself. So if we look from the left to the right, we see that the lumen actually is a place where bacteria and food products commingle, and the nutrients are digested down to building blocks such as amino acids and peptides and simple carbohydrates and fatty acids. And they play important roles in terms of promoting certain bacteria. They can act as signal molecules that actually affect the permeability of the gut, and in turn that will allow access of bacterial products or even food products to the immune system. The other very important fact, which is known from the early description of Crohn's in the 1930s, like Dr. Binion discussed about, is that a lot of the IBD patients, specifically Crohn's, when the surgeons are looking at a bowel, they see this proliferation of fat and this is associated with inflammation. And initially we thought this is a bystander effect, just inflammation in the gut, and the fat happened to be there and it gets inflamed. However, we now know that the adipose tissue surrounding the bowel is an active player in this inflammation. And you can see how diet and obesity actually can work together and create inflammation from outside to the inside. In fact, my lab actually looked at animal models of inflammatory bowel disease, and we found out that hormones in the fat can either promote or block inflammation. And in those models, when we gave adiponectin, which is a hormone made by the fat tissue under healthy conditions, we're able to block inflammation of the gut. Whereas in cases where the level of this hormone was low, there's more inflammation, more fibrosis in the gut. And something also possibly connected, for instance, to the COVID is the fact that the renin-angiotensin components are actually active into the fat tissue, but also in the gut. As you may know, the enzymes that process angiotensin, it's at this highest concentration in the gut mucosa. And so the substrate coming from the fat tissue actually then be transformed and can participate in inflammation. So we can see that, in fact, obesity is a state of health that is intimately related to this kind of inflammation. So going into this direction, we can think in a very basic way in terms of the life of a cell, right? The energy hub for us is mitochondria, which produces the ATP and allows all the processes to proceed. And we now know, for instance, that the way, for instance, energy is processed in immune cells like T cells or dendritic cells would determine in which way they polarize. Are they becoming Th1 cells, for instance, that make interferon gamma and TNF? Do they become Th17 cells that make interleukin 23 or 6 or others? And then do they become cells that block inflammation like Tregs? So metabolism and mitochondria becomes a very important target now. Just recently, a paper was published where they looked in patients with ulcerative colitis, and they noted that a lot of the enzymes that participate in the function of the mitochondria were actually altered in UC patients. And when they created mouse model lacking one of those components that control the mitochondria function, they're able to change the severity of colitis. And in fact, if they gave those mice medications that restored mitochondrial function, they're able to actually change the fate of inflammation. So we see that going down to the basics in terms of the mitochondria makes sense. And we already know that chronic state of obesity actually and inflammation leads to activation of immune pathways that are common in also sensing bacteria, like the toll receptors. And the same pathway actually can lead down to creating stress in a cell. And the cellular stress actually has been demonstrated to be important for the, leading to bowel disease. And in fact, many of the genetic studies, animal studies, even human studies showed that very important cells in the bottom of the crypts into the colon, we call panna cells. These are cells that actually make our own antimicrobial, our own antibiotics are made by these panna cells. And the function of these cells is affected when the mitochondria is dysfunctional or when the stress, even stress connected to a high-fat diet, actually leads to decreased function. This also actually impacts the stem cells, which are next to panna cells. And we know that panna cells are like feeder cells for those stem cells. So regeneration from trauma, from inflammation that we see in chronic inflammation will be impacted if we have this dysfunction, which can be a consequence of obesity or a Western diet, such as a fat diet. And so I also wanted to mention that our data and others have shown that overweight and obese IBD patients are more likely to have complicated course. In the case of Crohn's, more likely to have stenosing disease that leads to surgery. There's a high risk of refractory perineal disease. And then in ulcerative colitis, it's a higher risk of progressing to pancreatitis as opposed to proctitis and less-sided colitis. So we can see that intervention that leads to preventing or treating obesity, among other things, change the phenotype and the tone of disease. The other thing that I would really want to make you aware of is the high incidence of fatty liver and insulin resistance in inflammatory bowel disease. And we now know, we have our own study now almost to be completed when we looked at the incidence of fatty liver and NASH, the more advanced part in IBD patients. And interestingly, independent of their BMI, this appears to be affecting over 50% of the IBD patients and more likely patients that are on biologic therapies with more severe disease. So I think that this is really an important factor that we need to pay attention to, because obviously it can lead to cirrhosis, but on the other hand, we can look at this as a readout, right, for possibly insulin resistance and the risk of cardiovascular complications in patients with IBD. Now, sort of connected to this interaction between obesity, diet, and microbiota, I want to show you here data that came out from multiple groups, including our own group, where particular food products such as broccoli, cauliflower, for instance, they can be sources of certain ligands, in this case, the I3C or indole-3 carbinol, and they specifically engage a pathway that we have described in inflammation in colitis called the aryl hydrocarbon receptor pathway. And you may be familiar with, for instance, the PCB, the superfunds, where these toxins are buried in the ground, and now they're part of the diet or water, and they have been connected to a lot of cancers and other autoimmune conditions. But what we have been finding as well is that these toxins can be also accumulated into the fat tissue. On the other hand, the same pathway can be engaged by compounds from these vegetables with a whole different activity. So because of the specificity of how they interact with immune cells, they can lead to actually blockade of inflammation. In this case, for instance, the addition into a mouse model of those compounds that we find in these vegetables have actually led to a change in the type of immune cells we have in the gut, and a switch from the cells we call TS17 cells, which, by the way, they are a target for ustekinumab, and switch to the immune cells that actually block inflammation. So that's a very important finding. The other one was that this product actually instructed other immune cells in the gut to produce interleukin-22. As you saw earlier, interleukin-22 can be a marker of response to ustekinumab, but it is also a driver of this antimicrobial proteins that are made in the gut from the Panna cells. And by doing so, it's actually regulating what lives in the gut. So as opposed to on the left side, where bacteria lead to inflammation and destruction of the mucus and chronic inflammation, this rebalancing through these antimicrobial proteins favor microbes that actually lead to production of these short-chain fatty acids, which actually encourage cells to restore their balance, to restore connections, to reduce the leakage through the impaired barrier, but also to lead to enhancement of this immune landscape that leads to downplaying of inflammation. So I will now walk you through a few large prospective studies that actually looked at possible links between specific diets and inflammatory bowel disease. And at the bottom of this is the fact that we have looked at Western versus Mediterranean diet, essentially. And in this study, the Nurses Health Study 1 and 2, you had this very large number of female patients, 120,000, and they were ages anywhere between 30 to 55 and 25 to 42. And they were followed in terms of their medical promise of the appearance of inflammatory bowel disease, and also through symptoms and consumption of certain dietary products. There's some criticism, though, in terms of applying this observation to IBD population, because a lot of the patients that were found to have IBD in the cohort were a bit older than 40, so not as representative of the younger population. What they found, though, is that the consumption of fiber actually directly correlated with the low risk of Crohn's disease. For the ulcerative colitis patient, they found the ratio of the omega-3 to N6 polyunsaturated fatty acids was connected to the risk of ulcerative colitis. The other controversial thing is that you hear many times people talking about red meat versus white meat. And for the most part, the Western diet, which is rich in red meats, have been shown to be associated with inflammation in animal models of inflammatory bowel disease, but also in human studies with patients with cardiovascular conditions, for instance. Although this appears now to be more complex because specific mutations, genetic phenotype and genotype actually have been linked to this risk. So not everybody that consumes red meat appears to be at the same risk. The other observation was a link between the dietary sodium and the risk of disease. And in this case, this association was weak. However, other studies have linked the amount of sodium in the diet with the polarization of the cells into the Th17 direction, like we mentioned, the target area for one of the biologics they used, echinumab. The intake of zinc has been linked to a low risk of Crohn's, and also for both UC and Crohn's, the daily consumption of potassium actually has been linked to that. And in general, if you look at those that eat a lot of fresh vegetables, so those that are either have Mediterranean diet or predominantly vegetarian diet, they tend to have higher potassium consumption per day. And this was associated with low risk of both UC and Crohn's. Again, very interestingly, this phenotype-genotype interactions where specific mutations in the interleukin 23 and 21 have been connected to the absolute risk. Other studies were also interested in determining if perhaps certain food items have been associated with more inflammation in the serum, and whether we can use that information to calculate a score and say, if you eat items A, B, and C, your score is this, and then is the score correlating to the inflammation? And they have used the population from the nurses' health studies, but also from the health professional follow-up study, which including a significant amount of men. So they looked at the items they ate. Like I said, each item received a certain score in terms of the ability to create or not inflammation. And that score was based on the serum concentration of markers that associate with inflammation. In this case, the well-known CRP, the interleukin-6, TNF-alpha, and the TNF-alpha receptor 2. So the more of these markers in the blood were found, then you'd get a more positive score that associates with inflammation. Lower level equates to negative scores and protection. So then if you combine the sum of the things you ate, then this pluses and minuses lead to a certain score that might be associated with potential risk in terms of inflammation. So the one interesting finding, I thought, was the fact that independent of the amount of fiber, which we know actually it's strongly correlated with protection in terms of the gut inflammation, the lower the score for those items that they ate translated in a low risk of Crohn's disease. However, it did not apply to ulcerative colitis patients. In general, the items in the Crohn's disease cohort that appears to be protective were coffee consumption, red wine, and red wine has been shown independently in other studies. The resveratrol in the red wine is believed to be possibly inducing changes in the gut microbiome, and those changes translate in increased production of butyrate, for instance, that we know is protective for the colonocytes. The other ones were the dark-colored vegetables, and we know now, like I showed you before, that some of those vegetables, for instance, like broccoli, Brussels sprouts, for instance, also release compounds that engage the pathway associated with blocking inflammation. The typical enemies, right, in the diet, in the West diet, was actually shown to have high scores, so as the calorie dense, animal proteins, fatty foods. But I say that the biggest surprise was the pizza. So you think pizza is, right, a lot of cheese, fat, and is bad. However, surprisingly, in their study, it had one of the highest negative scores. So I'm not sure that we necessarily see this as a confirmation. Obviously, the study was not really designed in a better way to show that is a cause. But in a way, they explain is that possibly if you have pizza, for instance, with tomatoes in particular, they thought the availability of lycopene that's found in tomatoes, which is fat soluble, would be highly absorbed, especially in the environment of the fatty part of the cheese. So that's how they explain it. But obviously, this is hypothesis, and it's not demonstrated. So I think that the absolute risk of the diet, it's hard to quantify. And I think that just looking at the inflammatory markers is probably not the only way. And I think connecting this to alteration in gut microbiome and maybe mucosal healing in studies of IBD, it's really important. So the other study was a European study. Again, they used similar populations. And it was also demonstrated that the anti-PUFA acids, for instance, lower the risk of ulcerative colitis. The diet that's high in like sugary drinks, especially in patients that were low in fiber intake, appeared to increase the risk. Again, the alcohol to some degree appeared to be protective, particularly the red wine. And again, this theory that then and findings actually that showed that the bacteria, the fecal bacterium Prausnitzi, actually that it's part of those that make butyrate appears to be one of the protective factors. So now I want to switch gears a little bit to other ways in which people try to modify diet. So there's a possibility that when you consume a normal diet, you have proteins that end up being recognized as antigenic molecules. So in that regard, you can think of gluten, for instance, in patients with celiac sprue. If you break down and in the protein in certain parts, it can become a target for the immune system. But if you continue to break it in smaller amino acids, it will lose that ability, right? So processing the diet, creating this enteral nutrition with very simple components like carbohydrates, fatty acids, and amino acids may somehow reduce the antigenicity and the ability to trigger the immune system response to diet. So essentially, studies were conducted in both adults and pediatric patients. I would say that overall, the benefit that was shown in clinical remission and even mucosal healing was stronger in pediatric patients than seen in adult patients. And studies have been conducted when in pediatric patients where a comparison was made between those studied on steroids versus enteral nutrition. And it was shown that enteral nutrition in the pediatric population was similar to use of steroids. So obviously this is a much better approach in those patients because we know the growth retardation that occurs with steroids, which is particularly important in that patient population. What is important to know is that whether the diet was elemental or semi-elemental didn't quite make a difference. The perfect elemental diet is not necessarily what you have to go for. So almost any of these diets may be helpful, and like I said, possibly because they're lacking the entire proteins into their composition. So one of the things with this approaches is obviously patient compliance. I mean, how long a patient is willing to actually stay on a liquid diet with the elemental diet as opposed to more regular diet. And in some cases, maintenance was tried by, instead of having a continuous administration, that they have cycles of enteral nutrition interposed with more regular diet. And this appears actually to have worked. And in a study, actually, this was actually contrasted with maintaining patients with azathioprine, and they found that if the azathioprine was combined with this cyclical administration of enteral nutrition, was almost double the patient that had a clinical response, 67% on the combination versus 34% on the azathioprine alone. So the other approach is to follow a diet that excludes things that are known to cause possibly a reaction in terms of permeability or even immune system activation. And this is akin to diets possibly that we use in things like eosinophilic esophagitis or enteritis, right? So in this case, they have diets excluding gluten, dairy products, animal fat, processed meats, soy, canned food, and emulsifiers. So initially, it was an open label that showed about a 70% clinical remission, and a significant number of patients also had a decrease in the CRP. So this appeared to show benefit. The other study was to randomize patients to either having this exclusionary diet or having what we showed before, the enteral formula. And they have seen that the diet that excluded these items was comparable to the enteral nutrition, but they felt that patients were more compliant with the exclusionary diet. Next, I want to go to two very popular diets. And you might have had patients that are using either this low FODMAP diet and the specific carbohydrate diet. The low FODMAP diet, it's based on a principle that specific carbohydrates mainly present in the fruits and vegetables can enhance fermentation, and that fermentation leads to production of gas and water and leads to symptoms such as cramps and diarrhea. And to some degrees, diets are similar. However, with the specific carbohydrate diet, for instance, it's mostly simple monosaccharides allowed, such as glucose, fructose, galactose, for instance, SED diet allows for things like honey, which obviously is a source of fructose, and this is something that typically in the low FODMAP diet is not allowed. There's other components they're definitely excluded in the low FODMAP diet, such as onion and garlic. Again, they are considered to be more fermentable in terms of the effects on the GI tract. However, neither of this diet were shown based on objective ways, such as endoscopy or inflammatory markers, to be significantly altering the course of inflammatory bowel disease. I think that both in IBD and in patients with irritable bowel syndrome, which can coexist in IBD patients, have definitely shown benefit with both diets. And the benefit in most of the trials were similar between the low FODMAP and the specific carbohydrate diet. However, it appears that patients tend to tolerate and stay longer on the SED diet rather than the more stricter low FODMAP diet. The other part I wanted to discuss, because there are many patients that are self-imposing on gluten-free diet. And it is true that in IBD patients with a slightly increased risk of celiac sprue, and they may truly have a gluten problem in that regard. However, patients may also have a gluten intolerance, which is not celiac sprue. And the gluten intolerance, it's an evolving definition. Oftentimes it requires a challenge with the diet in addition to the markers for celiac sprue that typically would be negative. However, what we know is that specific things, for instance, such as the amylase antitrypsin inhibitors, which are sort of antipathogenic proteins produced in the wheat plant, may actually trigger a response from the immune system and can alter gut permeability and create symptoms similar to celiac sprue without actually creating the histology that you see on biopsies in patients with celiac sprue. The other interesting found was in clinical studies in the past 2 years that a lot of the wheat-containing, gluten-containing cereals, and we actually see that they have a higher content of fructan. So it is believed that actually the fructan in this compounds, it's leading to symptoms, it's not the gluten itself. So I think it's important to kind of discuss with the patients, because being on a gluten-free diet is not necessarily a healthy habit. And in fact, by the dietary restrictions, we see a lot of these patients gaining weight. And we already know that IBD patients paradoxically can have a weight problem, and then they can be at risk of diabetes and metabolic complications. The other thing that we have to think is that in general, in the immediate time at least, and if you look at most of the randomized trials that were done with dietary products, were usually fairly short, less than 6 months, and then they mainly impacted symptoms and not as much the objective ways of measuring response like we saw in the earlier talks, the healing, the histology, or the inflammatory markers. But one thing that is obvious is that if you do change the diet, you will probably see a change in microbiome. And we know that the microbiome diversity, it's very important in IBD, and the dysbiosis and the abnormal immune response to bacteria, it's what actually leads to development of inflammatory bowel disease. So we can think in terms of the goals of the diet. It doesn't have to be only altering symptoms or only altering inflammation. It's can we alter bacteria, because that can have long-term implications. It may alter response to biologics, but it can alter, say, recurrence after surgery or development of complications like strictures and fistulas. So we know, for instance, that human milk contains oligosaccharides, and it promotes the Bifidobacterium longum and infantis. And this is important. And then I think that we should recommend to all women, IBD women that have children, to try to nurse them for more than 6 months. In fact, most of the studies that show protection in autoimmune conditions from breastfeeding actually indicated that at least a 6-month period is necessary. But as you can see, it's not just about nutrition, it's the human milk being able to change the landscape of the microbes and hopefully the phenotype of disease. The other one that's been shown over and over again is the amount of fiber in the diet. So the high fiber diet actually can lower the risk, probably Crohn's more than ulcerative colitis, but certainly it should be recommended to both groups. And then if we look at a famous study with children from Burkina Faso and Europe, for instance, they found out that the increased fiber in the Burkina Faso children associated with bacteria that were able to produce more short-chain fatty acids, and they saw lower incidence of asthma and other autoimmune conditions. So certainly this can have long-term effects. The other thing that I want to draw attention, which it's easy to overlook, is that the artificial sweeteners actually can be a driver of disease. And in fact, there are many landmark studies, more specifically an animal study, that showed promotion of inflammation in the gut. And in fact, some of the changes in bacteria that are associated with these artificial sweeteners actually also lead to glucose intolerance and even diabetes. And we know this relationship between energy, mitochondrial dysfunction, and obesity and inflammation. So I think this is something that we should really pay attention to. Avoiding high-fat diet, it's I think pretty much established now, and then typically recommending the patients a Mediterranean diet will essentially assure a diet which is not a high-fat diet, and hopefully that we see specific bacterial phyla actually increasing, such as the Rominococci and Lachnospirae, that are lowering the risk of these patients. The high level of lecithin in the diet, for instance, it's a problem because this can be processed by bacteria in the gut. And in fact, the 3-methylamine that results from this microbial metabolism has been shown to lead to fatty liver, which now know, like I told you, that it's a higher incidence seen in IBD patients as well. And then it may explain, in fact, why patients that are lean, right, with the normal BMI, normal waist, actually, they can have fatty liver, and it's not necessarily diet itself, but it's this interaction of specific bacteria and gut microbiome actually leading to fatty liver in patients that you traditionally wouldn't think to screen. Lastly, in terms of the micronutrients, obviously there are many deficiencies in IBD patients, but I want to focus specifically on vitamin D and iron, which are very common deficiencies. And I think that sometimes there are misconceptions on how we address this. And I want to say that a lot of the people, when we say vitamin D, they think osteopenia, osteoporosis, and it's bone health. Yes, this is important, but we also have to know that all the immune cells in our body, they do have receptors for this vitamin. And there's ample evidence that vitamin D regulates the immune system and actually can help turn off inflammation. And in fact, the moving away the cells from making that TNF or interleukin 23 or 12 through this Th1/7 polarization can be reversed, at least in animal models, towards the Treg, the cells that block inflammation. There's also evidence that vitamin D can be protective in cancer, which we know afflicts some patients with inflammatory bowel disease. Some studies are disappointing in a way. So a recent study, for instance, that looks at vitamin D can actually prevent post-op recurrence, and that failed to materialize. However, other studies that looked at vitamin D supplementation in terms of inflammation have been positive. It is important to note that in the recent study where the post-op benefit wasn't shown, is that it wasn't a treated target for vitamin D. So I think that when we treat vitamin D, level matters probably. Like many of the patients that have vitamin levels between 30 and 40 may be thought of as normal levels, and many may not receive supplements. However, it's important to know that vitamin D can exist bound and free. And usually when your serum vitamin D total it's around 40 to 45, you have the maximum amount of free vitamin D circulating that's more active. So once you reach that goal, then beyond that, there's probably not as much benefit to go much higher. However, maintaining the vitamin D in the 40 to 60 range may be beneficial over long term. It is also important to know that these patients appear more refractory to replenishing vitamin D. And oftentimes we have to do this high weekly dosing of 50,000 units per week for 8 to 12 weeks in a row before we can actually get the vitamin D in the more normal range. The second problem here is iron. And iron deficiency is very complex inflammatory bowel disease. And it's not just a mere drop in iron because you're bleeding and you have active disease. One of the things that happens during inflammation is a certain hormone called hepcidin, for instance, is made by the liver in the same way a CRP is produced as an acute phase reactant. It can actually lead to blocking the absorption of iron from the gut. So in fact, when you treat inflammation, beyond the fact that you treat the gut and prevent loss, you actually turn off that hepcidin production that in turn can increase your oral absorption. However, during active colitis or ileitis, the oral iron may be deleterious. And primarily we have information from animal studies where, for instance, in one of these studies, they looked at animals with colitis where they were randomized to either get oral iron or IV iron, and those that received IV iron had a much faster recovery. And it's believed that it is the activity of iron, so the higher amount of iron in the gut may actually promote the bacteria that lead to inflammation, and maybe there is some injury to the mitochondria and the endoplasmic reticulum, which are important parts of the cell, and this oxidation state may further promote inflammation. So in general, in patients that are severely iron deficient and anemic with IBD, we think that during those active states of disease, the IV iron replacement might be a better way. For one, is that it will take much faster. You may avoid issues with oral tolerance in general to iron products, but it also may be mechanistically making sense. So I would want to also address early life events. We have seen in some nice studies from Mount Sinai recently, for instance, early exposure to certain heavy metals like they're found by looking at the concentration in their teeth, can be leading possibly to IBD onset. But I think that the other thing that we have to keep in mind is that the way you're born and the way you're fed in the early life can have an impact on your microbiome. And as we know that the immune system is not fully developed, then in turn that microbiome will actually shape your gut immune system and will set a tone whether you will have or not inflammation, especially when your mother or both parents had inflammatory bowel disease. So for instance, the delivery mode has been shown to possibly influence microbiome. And so vaginally delivered kids have a microbiome early in life that's more like the normal GI tract type of microbiome, whereas those that are born by C-section in the first days of life, they have bacteria that resemble the skin microbiome. The other thing is that children that are born maybe premature, or those that are not fed by breast milk, they may be exposed to formula. And several studies actually have shown profound changes in the diversity and composition of the microbiome. And this can actually lead to either risk that can be higher or lower, depending also on your genetic makeup. But I say that promotion of the type of birth and then promotion of breastfeeding can have a lasting impact on autoimmune conditions. And even recently, there was an interesting study that came out that even they show that supplementation of mother's milk with certain bacteria may actually enhance the activity of this mode of feeding. So I will end up with a practical approach. I think that certain tests we can do for the patients would actually allow us to be more successful in implementing a food approach to at least addressing symptoms and hopefully long-term changing microbiota and disease course. But it is very important then we check for celiac sprue, because I don't think the gluten-free diet just by itself with not having a knowledge is healthy. Testing for lactose intolerance. Like it was said before, bowel salt diarrhea is important. We can do the 7C4, which is an intermediate in the bowel salt synthesis, and then you can find out whether a patient is more likely to have this bile acid-induced diarrhea or not. The other thing that people overlook is the overgrowth of bacteria. So patients with IBD, they have from the get-go dysbiosis, but oftentimes, like you saw, they have surgeries, and this change in the anatomy, the lack of the ileocecal valve or a specific anastomosis can actually create a change in the small bowel environment that leads to overgrowth of bacteria, and that in turn will determine how you digest food. So if we don't test for this, patients may be avoiding food items like those on the high FODMAP just because of this problem. So, and this is something that can be addressed with a course of antibiotics, and that may allow the patient to have a more regular diet. The other thing is that to be successful in implementing a diet, we have to understand their beliefs, their background. We have to know what else they're having over the counter, and also to put things in context. Oftentimes our patients have anxiety and depression, and so trying to implement a dietary change that requires some commitment will be far harder in a patient that has not been addressed in terms of their anxiety and depression, for instance. The other thing is that diet alone is not going to do the trick. And then we have to understand the role of exercise, the sleep hygiene. They're all very important components in actually changing metabolism and sort of allowing this metabolic switch that potentially can be helpful as far as inflammation is concerned. And then for those who treat IBD patients and they try to make dietary interventions, I think that we have to have a knowledgeable nutritionist and dietitian involved. And I think it has to be an open dialogue, because oftentimes you tell something to the patient, they see a nutritionist, they get a whole different message. And especially I think that one of the dangerous ones is when they say, oh, you can do this diet and you don't need the therapy. Like we saw, symptoms are not equal to activity. So just because a diet is going to actually reduce or completely eliminate your symptoms, it doesn't mean that you have changed the fate of inflammation. And I think those people are in danger of complications and surgery because they mistaken the lack of symptoms with lack of disease. So I want to end up saying that when we do diet interventions in IBD, we have to be creative, we have to make it fun, and at the very least to associate with exercise. Thank you. So the first question for the Hanauer. The question is, what are the possible reactions to biologic agents that I need to be on the lookout for on our patients on chronic biologics, such as new onset worsening CHF?
Well, thank you very much. And hello to my friends from a distance. And I'm sorry I can't be there, but I can't be anywhere right now except here. So what do you need? What are the warnings for biologics? Well, each biologic, of course, has its own categories of warnings. The TNF inhibitors. TNF is very important for intracellular killing of pathogens such as tuberculosis and also encapsulated organisms. TNF has also been anti-TNFs have been tested in 2 other situations, actually 3 outside of the inflammatory diseases. One was in HIV, where it was not efficacious. The second was in heart failure, because in heart failure, excess TNF is produced. And indeed, in class 3 and class 4 heart failure, TNF inhibition made it worse. And the last one that we really need to be consider are demyelinating diseases. TNF inhibitors have been associated with the development of demyelination and have actually made multiple sclerosis and other demyelinating diseases worse. So in very broad categories, those are the 3 that need to be concerned about with the TNF inhibitors. And I think I'll stop there.
Thank you, Steve. Next question from Dr. Lichtenstein. How high is the risk of lymphoma in patients taking biologics? And is it dependent on duration of use, or do they get a drug holiday to reduce the risk?
An excellent question. I'd also like to say hello again from a distance. The question is often we ask, is it biologics alone, or is it a combination with immune modulators? And we recognize the risk with immune modulators depends on the age of the individual patient. So a young patient, say a male, under the age of 30, 35, the standard incidence ratio is about 9-fold. In a female, it's approximately 5-fold. Someone over the age of 50 has a 1 in 364 patient year follow-up per lymphoma based on a meta-analysis that we published approximately 3-4 years ago. So this is something one has to look at, the age as well. Only 2 studies with azathioprine looked at duration of disease, and duration portended a higher risk over 1 year. Hepatosplenic T-cell lymphoma subset is 2 years based on data we had published as well. But again, it's not a black line in the sand. With regards to the data for general population risk, the general risk in the population is 2 per 10,000 patient years of follow-up, is the general number that we banter about based on the SEER database. With regards to the anti-TNFs, it's approximately a 3-fold risk. This is, though, controversial. This is based on data from Lemaitre, data from which Steve and I were involved with, the TREAT registry, did not show a higher risk for lymphoma. So it's somewhere between no higher risk to 3-fold, and we all believe it's in the range. Age itself was not looked at as a risk, but this is age-adjusted risk based on the standard incidence ratios that one has. Now, one has to balance risk versus benefit, as we always say, so it's not just the risk of getting a side effect, it's the benefit achieved. It's important to look at as well. Excellent question, though. Thank you.
A question for Dr. Binion. What is the role of exaltants in IBD, especially if the patient failed a TNF blocker?
The question was, what is the
what is the role of exaltants in IBD, especially in those that fail TNF?
He means tofacitinib.
Yeah, I apologize. My computer froze. Thank you, Steve. So small molecule inhibitors are a new class of drugs that we're getting used to in the IBD space. Right now, the drug tofacitinib is reserved for people who have failed an anti-TNF, but we're starting to see commercials on television for some of the newer small molecule inhibitors that have been going through the FDA approval process. So there's a compound, hepatocellular, that's already become available for the rheumatoid arthritis patient population. So these agents are kind of rescue agents right now for IBD. We can't really use them early on. We have to go through typical biologics, the anti-TNF class of drugs. We're also positioned sometimes fairly low down when it comes to the payers and the insurance companies. I've used them on a small number of people. They can work very nicely. We do have to be a little bit more careful. There are some concerns regarding clotting that has emerged in the rheumatoid arthritis patient population. But in general, herpes zoster is perhaps the other thing we need to be careful about. So these agents are going to increase. I always tell my trainees that when you see commercials for the veterinary medicine for dog itching, the drug Apoquel, that's essentially the same molecule. That's a JAK inhibitor, a non-selective JAK 1/3 inhibitor that's being used pretty widespread in the veterinary medication world at this time. So I think they're going to come. We're going to have more agents available as time moves forward, and then we'll become more familiar with their use.
But just be cautious with the off-label use of hepatocellular in Crohn's, because remember, it's the same with all of our agents. In rheumatoid arthritis, the dose is about 50% what's required for IBD. And the dose that's used in RA has not been effective in IBD thus far.
One thing I might add that's important to recognize as well, just to highlight, that serum albumin is not a predictor of non-response with tofacitinib. So those are things that should be looked at in the right clinical setting. And it has been used off-label as rescue therapy for patients hospitalized if they have failed anti-TNF, and small numbers of patients have been reported in the medical literature. And Steve published data that the onset of action is rapid within 3 days. The response comes about based on the trials. So I think these are options to consider in the right clinical setting.
The other question is, should a primary medical doctor manage and titrate new meds in IBD? So I think that's an important question. And a short answer would be that I don't think that management titration has to fall on a primary care physician role. However, I do think that the collaboration between GI, the IBD specialist, and primary care is very important. Like it was mentioned before, there are safety issues regarding these therapies, and I think that one of the goals for us is to minimize the risk. And so assuring vaccinations is very important. And I think this is a collaboration that we have to have with the primary care, making sure that they have certain screens for cancers can be helpful in terms of pap smears, mammograms, process screening for men, but also dermatology consults. Also, like I mentioned before in my talk as well, we see this higher incidence of insulin resistance and diabetes. So I think management of obesity actually can be a common goal, and it may be something that can change things in almost any autoimmune conditions, for instance. I think that the other patients that may intersect between us and primary care would be elderly patients, actually their risk and co-managing in terms of their risk of clotting, like was mentioned with exaltants, but also in terms of cancer risk and then their history of cancer. The other one would be a younger group of women that are pregnant, right? So I think that understanding the risk of therapy, but also risk of discontinuation of therapy in pregnancy is important. And we oftentimes see patients that are doing well because they're pregnant and they see their primary care physician, and out of caution, sometimes they are advised, for instance, to stop their biologic therapy, which is not necessarily what we are recommending. And then I think that the risk of flare may be a problem. So I think that the open dialogue has to exist, and I think that the primary care can play a role in all these issues, but not necessarily being in charge of monitoring and titrating, which is still something that it has to be done by an IBD specialist. More so that we have new targets now. It was mentioned because of healing, histologic healing, and obviously even the definition of a normal level, it's a bit of a contention, right, in our world as well. So I think that part should be managed by the IBD specialist. But recognition of side effects is very important, and oftentimes symptoms that may not be gut symptoms, like the extraintestinal manifestations of disease, can be indicating that a patient may have a flare. And utilization of simple markers of inflammation would be very helpful to determine that a patient is about to have a flare, and notify the IBD specialist, such as obtaining a stool calprotectin or lactoferrin, maybe the CRP, an albumin. They can, in aggregate, inform that a flare is coming up. It may indicate maybe there is something wrong that has to be titrated, the biologic has to be adjusted, but also to be cognizant of side effects, like we mentioned, clots, certain cancers, but also more opportunistic infections, certain viral infections like EBV and CMV, which may not be always on the radar of a primary care physician. It has to be looked at from the perspective of immunosuppression. Okay. Okay. There's another question about, does the insurance company know about the IV versus oral iron replacement? Again, I don't think this is something set in stone. I think that, like I said, there is data to suggest the possibly IV iron being a better way to supplement iron, and then that can be looked at from a point of tolerating oral iron, how fast this is replaced, but also potentially effects on disease biology too. I guess this would be a discussion of the individual in case of a patient being denied for IV oral therapy. I didn't have in particular in my practice a problem with that. We oftentimes work with hematology, so I think that having that relationship, it may be helpful, but this would be an individual cases decision. All right, so I would thank you to all the faculty, and hopefully next time is going to be in person. This is a very nice venue here, I can tell you, if you like golf. And the color of the fall, it's fantastic, and the weather is nice. And I thank you everybody for being here today, and those that are online. And I will remind you that the next session will resume at 3:25. Thank you.
Possible. What I will be discussing is the cholestatic liver diseases. And when we say cholestasis, usually my fellows and my students say the increase of bilirubin. Actually, you know, when the bilirubin is high, especially the direct, the horse is outside the barn. So cholestatic liver disease, just to start from the beginning, are diseases that the cholestatic enzymes are increased. And this is the alkaline phosphatase and the GGTP. And make sure that the alkaline phosphatase is coming from the liver. It's not coming from the bones. It's not coming from the intestine. It's not coming from any other organ. Primary biliary, and these are my disclosures, research. Primary biliary cirrhosis was named many, many years ago. This is not a disease that was recently identified. In 1851, we have the first announcement by Addison. Yes, he's the known Addison who developed the Addison disease, among other things, and Dr. Gall, that they were discussing this vanishing of the bile ducts along with jaundice. And in 1950, Ahrens and some colleagues came with the idea that this is a disease that has to be named primary biliary cirrhosis. And of course, everybody got nervous for approximately 130 years, because when you say to somebody you suffer from cirrhosis, the first thing they think is that they need a liver transplant or they are gonna die. Now, a few years ago, we have the official change of the name from primary biliary cirrhosis to primary biliary cholangitis, which is something that represents much more accurate this disease, as just only a portion of these patients will develop significant scar tissue, fibrosis, and ultimately cirrhosis. What kind of the disease is this? The way I'm describing that to the students, and you know, the students would like to have everything ridiculously simply nowadays, is the way you see a tree in the winter. What do you see? Just close your eyes and imagine. You see just branches. And suddenly somebody's coming in and starts pruning the smaller branches, moving towards the main trunk. In other words, perhaps this is an autoimmune liver disease that appears to some patients with genetic predisposition. Something else is triggering the expression of these genes, like environment. And suddenly you see that they develop all of these wonderful small dots, as you see in the illustration, which are the lymphocytes attacking the main structure that you see in the middle, which are the bile ducts. So they develop dactylitis. And the first thing that is going high is the alkaline phosphatase and the GGT. This disease actually has been noted that is increasing in incidence, or perhaps we're checking more people nowadays and we are able to identify more of this. This disease is affecting mainly ladies. If you have 10 people, 9 of them will be women. Very, very young age, at the age of 50 comes. You know that the life expectancy of a woman right now is about 86, so 50 is pretty young. That has been noted in patients over 90 years old. And there is some preponderance in patients actually that they have some genes like HLA-DR8. If we look at the young ladies at the age of 40, this is the leading indication for liver transplantation in this population. And this is what we discussed earlier. You see that as the years are passing by, we see more and more ladies coming in with this disease. Why? What's going on? Perhaps environment, perhaps more infections, perhaps something we don't know yet, but definitely is increasing. If we look at the pathogenesis, where does this happen? We don't know exactly, but we speculate that perhaps an infection, like these people tend to come down with urinary tract infections, is creating or unmasking some antigens in different organelles, like the mitochondria, in the bile ducts. In other words, the immune system forgets the tolerance against the plumbing system of the liver, the three we discussed earlier, the bile ducts, and starts vanishing them. And definitely people develop cholestasis, in other words, increase of liver enzymes and later on of the bilirubin, and develop scar tissue. And as the time is passing by, more and more and more scar tissue. And at the end, we have biliary cirrhosis. But let me go back. Take a look at that. Do you see the mitochondria? So what's the name of the antibody against the mitochondria? This is the AMA, the anti-mitochondrial antibody, which is the hallmark of the disease. This is the reason I put the mitochondria over there, to see actually that there is a specific part, which is the PDC-E2, that gets the major hit and the development of the antibodies. 30% of this population don't feel anything. The disease is identified during routine blood work. But if you ask me, what's the most common symptomatology? It's not itching, that the patient comes in scratching all over the place. But this happens later. These ladies feel really tired. They have developed significant hepatomegaly, in other words, an enlarged liver. Later on, they develop portal hypertension, splenomegaly, and jaundice, and some of them develop xanthelasma. You see the discoloration and the patches around the eyelids mainly. If we dig a little bit deeper, you will see that these people have dry eyes and dry mouth. This is the xerostomia and xerophthalmia. And the name of this is keratoconjunctivitis. This can happen actually 70 to 80%. They develop problems with the joints, arthritis. Some of them might suffer from mixed connective tissue disease and scleroderma. Some of them develop thyroiditis or some issues with the kidneys, as you see at the end, which is the renal tubular acidosis. In other words, the way you look at all of these things, this points towards what? Autoimmune disease. The first that is going high is the alkaline phosphatase, but we can have a mild increase of the aminotransferases. The bilirubin usually is early. When we try to perform a thorough immunologic investigation, we see the anti-mitochondrial antibody is positive. My mentor in the University of Athens used to say, if the AMA is negative, you need to send the patient to another lab. Perhaps it's a lab error. This is how strong this is. And if you try to dig farther, you will see that the anti-mitochondrial antibody has 9 subtypes. The second one, the M2, is the one which is very specific for this disease. Now we know that an anti-nuclear antibody, the GP210, can be positive. Sometimes we don't have all the information together, and we are obliged to take a liver biopsy. But do we need the liver biopsy? Looking at the diagnosis, we need 2 out of these 3. An increase of the alkaline phosphatase more than 1.5, a positive anti-mitochondrial antibody, and if we get a liver biopsy, we will see the bile ducts suffering. In other words, ductulitis. 2 out of these 3 are enough to make the diagnosis. So if you have increase of the alkaline phosphatase more than 1.5 and a positive AMA, you are done. Now, with a liver biopsy, we can get another important piece of information. In other words, how much scar tissue do we have in this liver? From 0 to 4, 0 normal, 4 cirrhosis, we can get a pretty good idea how much fibrosis does exist in this liver and ultimately what's the prognosis. But nowadays, do we really need to poke the liver? I'm a transplant hepatologist, and there is only one procedure that transplant hepatologists are doing. This is liver biopsy. Well, I hate it. I don't want to do it because this sometimes encounters complications like bleeding. You can puncture the lung. People come with pneumothorax. You can punch the kidneys. You can punch the gallbladder and all of these things. And nowadays, we have alternatives. What's the name of this? Elastography. In other words, you just put the probe between the ribs and you can get a pretty good idea in regards to the liver stiffness. As you can see in this illustration, blue is good. You see that these patients don't have much of scar tissue. Red is not that good. More than 9.6 kPa means that the patient has evidence of more advanced scar tissue in the liver, and that's why the survival is not the best. And these are the 4 stages that we have in regards to the histology in case we have a liver biopsy, going just from an inflammatory process, moving towards an inflammatory process, expanding from the portal areas to the hepatic parenchyma, later on having bridging, and finally cirrhosis. There are different scoring systems in regards to primary biliary cholangitis. But take a look at this. Which is the one variable that is coming in every single one? Just look at this. Do you see anything? Which is the variable that is across the board? You see the bilirubin. In every single scoring system, you see that the bilirubin is included. And I remember in the past, Dame Sheila Sherlock giving us a couple of ideas. Bilirubin more than 3, more than 6, and more than 9. More than 3, we're not doing very well. More than 9, you need to move forward and transplant these patients. Now, without treatment, the course extends over 15 to 20 years of period. Now, when the bilirubin is going more than 10, the life expectancy is reduced to 2 years, and people come down with significant complications. And of course, you know, looking at the different scoring systems, perhaps the Mayo risk score system that is pretty good in predicting survival, guiding us in regards to when to refer a patient for liver transplant and to monitor the effect of experimental medications in clinical trials is the one that is utilized the most. There are various response criteria, and as you can see, I don't know, but there is a tendency researchers to utilize the place they identified the criteria. As you can see, Barcelona, Paris, Rotterdam, Toronto, Mayo. I'm going to put one from Newark, New Jersey. This is what I am when I will develop mine. And you see that this is based on different variables like the alkaline phosphatase, AST, bilirubin, and albumin. Another criteria is the AST to platelet ratio, which is very quick to be done. And you can Google that, or you can do different searches. The formula is coming, and this can give you some good ideas. And of course, the mathematical models, the way we discussed earlier, like the Mayo, the Globe, and the UK PBC scoring system. And of course, the Globe score is another one that is actually utilized. And this is an online calculator that it is easy to identify. You see the variables that you use: age, total bilirubin, alkaline phosphatase, albumin, and the platelet count. And this predicts the 3, 5, and 10-year survival. How do we treat this disease? So lots of things have been utilized in the past, going from steroids to azathioprine, immunosuppression with methotrexate, cyclosporin, but we come down to 2 right now. The one is urso, deoxycholic acid. And why is the name urso? As you know, urso is the big bear, the polar bear. And of course, the farnesoid receptor agonist. Urso dilutes the bile, also has some additional hydrotrophic, actually replaces toxic hydrophobic bile salts. Some people claim that actually might be an immunologic action by decreasing the expression of different antigens, by down-regulating the expression of MHC1, and increases the canalicular bile salt excretion, and of course, stimulates chloride secretion. In other words, makes the bile flowing better, to make the long story short. And the utilized dose is 13 to 15 milligrams per kilogram of body weight. As you can see, that people that utilize this early stages of the disease, in other words, people without decompensated cirrhosis, when it is a little bit late to anticipate dramatic changes, this improved actually the survival free of liver transplantation and delays the progression to cirrhosis. So is this panacea or placebo? There are multiple trials looking at this compound from different standpoint of view. Long story short, early utilization of urso might have some benefit. If we are waiting or identify the patients later down the course, this is not the best way to do it. That's why different meta-analyses have produced different kind of data by looking actually how many people got the appropriate dose, the duration of the dose, and the follow-up. And of course, they resulted that significant improvement was noted in the biochemical values. If we do that normally, with a decrease of the alkaline phosphatase less than 1.67 and normal bilirubin after 1 year. And this actually was the best predictive outcome for this kind of patient. And of course, if patients respond to urso, because not everybody will respond as we discussed earlier, you see that they have a more prolonged cirrhosis-free course. And of course, they do not require liver transplantation. You can see the blue and the red line. This is for patients that began treatment in early stages. You will see the red line all the way at the end that patients began treatment in advanced stages. You see they didn't have the same life expectancy and the complications like other. Unfortunately, 40% of patients treated with URSO have a suboptimal response. We don't see the decline of the alkaline phosphatase less than 1.67. And this is the time that we need to switch gears and add another compound. The name is obeticholic acid. And this is the farnesoid receptor agonist that has been utilized actually for patients with primary biliary cholangitis. And of course, this amplifies the regenerative capacity of the liver. This is an acid, so we need to anticipate whenever we discuss that this is an acid that pruritus will come into the picture. But looking at the data, this can increase the fibrosis score. This can perhaps decrease the chance for people to develop portal hypertension, improves insulin sensitivity, and of course, steatosis, as it has been mentioned in some other trials, and the bowel homeostasis. This is the POISE trial where they utilized OCA, obeticholic acid 10 milligrams, and this was titrated up to 10 milligrams, or OCA 5 milligrams and remain at 5 milligrams versus placebo. And after that, they turned the trial to an open label trial. As you can see in this illustration, dark blue is the placebo. And you can see the obeticholic acid patients with 5 to 10 milligrams of red and 10 milligrams with blue. You can see a significant response actually as the time is passing by. In other words, patients are responding very well. And as you can see in this illustration, there is a decline of the alkaline phosphatase, even in the double-blind phase as well, that people in the beginning were blue. After that, they were switched to the OCA arm. You can see at the beginning, the blue is pretty high, and after that is dropping and is touching the red line. The same thing in regards to the bilirubin levels, dropped, and the same thing with the blue. In the beginning, the placebo is higher, and after that is coming down. As we discussed earlier, this is a bile acid, so we anticipate itching, in other words, pruritus. Some people might develop nasopharyngitis, headaches, fatigue, nausea. In other words, what do we need to do? So there is a new diagnosis for these patients coming in. Of course, we need to evaluate these patients and make the diagnosis of primary biliary cholangitis. We need to stage the disease. We don't need to do liver biopsies. We need to do imaging as well and exclude other diseases like bile duct obstruction. And subsequently, we put the patients on URSO. We are following these patients. As we discussed, 40% will not respond. If this is not responding, we need to switch or add the patient obeticholic acid. I'm switching gears, moving towards another disease, primary sclerosing cholangitis. That's a disease that mainly has been associated with inflammatory bowel diseases. So what is this? Again, close your eyes and think about the tree in the winter, and you see the plumbing system, you see the branches. Now, some of the branches develop strictures. In other words, while you have the branch, suddenly a portion of this develops a stricture. What is going to happen? The portion that is before that will get chubbier, will get dilated, and the remaining might not. So this is what we see. We see strictures and alterations of dilations with narrowing of the bile ducts, because the stricture actually is coming due to scar tissue. This is a progressive disease, and people develop subsequently fibrosis and, of course, cirrhosis. And this is what we encounter. Take a look at the dilations alternating with narrowing. And this can start from very deep inside, very small branches. What's the name of this? Small duct primary sclerosing cholangitis, or start from larger branches, and you can go down and you can see the strictures. These things actually might be a predisposition for infections because the bile is not flowing appropriately. And as you remember, one of the best materials to grow germs in the lab in microbiology is to have bile. Now, the incidence is variable, but it's increasing. There are some populations that are much more prominent, like the Northern Europeans. You see that very good studies came from Finland and the Nordic areas. And of course, something else that people are looking nowadays for everything is the microbiome, especially for patients with inflammatory bowel disease. Now, the median age of diagnosis is at around of the age of 41. As we discussed, this is a presumed autoimmune disease and has been associated with inflammatory bowel disease, celiac disease, sarcoidosis, rheumatoid arthritis. There is an increased chance for first-degree relatives to develop this entity. And when we try to go with genetic testing, there are specific HLA haplotypes that might be more prominent in this population. During the laboratory evaluation, the alkaline phosphatase is increased, and of course, the IgG. Now, the constellation of all of these risk factors, including genetic, environmental, immunologic, and might affect the bile ducts, and people develop this kind of the disease. How do we treat these patients? Unfortunately, and if we look at the guidelines, there isn't anything solid at this point to treat these patients. Speculations like urso along with metronidazole might give some good effects. Some people have tried minocycline, perhaps try to alter the microbiome. And some people tried vancomycin versus high dose of metronidazole for 12 weeks. There was a significant decrease of the alkaline phosphatase for patients receiving vanco-PO, like we treat actually C. diff. Next slide. Now, how do we diagnose? This is a more invasive way to do it. This is the endoscopic retrograde cholangiopancreatography. So you see in the left how smooth the plumbing system looks like a nice tree. On the other part, you see the stenosis and significant actually dilations of the bile ducts. Next slide, please. So we don't have objective criteria in order to make the diagnosis of these patients. The sensitivity and specificity of the magnetic resonance cholangiopancreatography, which is less invasive, is 86 and 94%. The liver biopsy sometimes reveals nothing. There are no specific antibodies. People might be asymptomatic. The only thing they complain about is some pruritus, some right upper quadrant pain. And sometimes it's difficult to rule out secondary causes for some patients. The cholangiopancreatography, as we discussed again, you see different dilations and different stenosis. Take a look how tight this area where the arrow is. To do a liver biopsy, well, if the cholangiogram is normal and there is a strong suspicion, then might reveal small duct PSC. Sometimes it's good to see how much scar tissue we have in the liver, in other words, the staging, and sometimes to rule out overlap syndromes. In other words, there might be 2 or 3 diseases happening concomitantly, like autoimmune hepatitis and primary sclerosing cholangitis. And this is the illustration, the classic feature you see in the liver biopsy, the way you see that in the left lower is the onion skin. You see the bile duct in the middle and something like an onion. In other words, pericentral, periductal fibrosis for these patients. How can we evaluate these patients in regards to how advanced the disease is? Elastography again with an ultrasound or with an MRI. Of course, I prefer the MRI, gives you a better idea, but sometimes they do not reimburse and the facilities don't want to do it because it takes time. The laboratory evaluation is revealing an increase of the alkaline phosphatase, an increase of the aminotransferases and the IgG in 60% of the population. The MRC or ERCP can give us a pretty good clue in regards to the disease, and liver biopsy can be utilized. This is the onion skin, as we say, and you can see how thick the scar tissue around the bile duct is. There are different antibodies, especially the P-ANCA that we have studied in the past, and actually this is positive for the IBD population. Sometimes you can see SMA or ANA, but you see that it's not very common to have something like this. What's the algorithm for the diagnosis? Of course, we have the biochemical profile. We do an ultrasound. The anti-mitochondrial antibody is negative, so we are moving away from the diagnosis of primary biliary cholangitis. Subsequently, we're asking for an MRI with emphasis on the bile ducts, MRCP. If it is diagnostic, we have the disease. If it is non-diagnostic and we have a strong suspicion, we can ask for a more invasive procedure, which is the ERCP. And if all of them are normal, then we can entertain the possibility of doing a liver biopsy to diagnose small duct PSA. What are we doing for these patients? Also, again, high doses actually increase the risk of death, and the trial was stopped. So we can try also 10 to 15 milligrams per kilogram per day. It has been noted that for some of these patients, the biochemical profile improved. What else can we utilize? I don't know if it is an alternative or voodoo medicine, because all of these things have not been proven to be highly efficacious. Besides, some people utilize vancomycin and metronidazole. FXR agonists like OCA, the one we described earlier, are currently on trials. There are some humanized monoclonal antibodies, and of course, vedolizumab. The trial did not. Some preliminary results were very encouraging. I'm not sure if this is the best way to do. 25, about a quarter to 50% of the population might be waitlisted. Something that we need to be very, very cautious is that primary sclerosing cholangitis can predispose to cholangiocarcinoma. And this is very important, and we need to keep an eye for this. Or some people might develop significant cholangitis because the bile is not flowing down to the gut, and people might develop sludge and stones as well, and subsequently infections. So looking at the American College of Gastroenterology clinical guidelines in regards to primary sclerosing cholangitis, as we discussed, we measure the IgG levels in patients' diagnosis. We need to look for patients with varices if the platelet count is low. We need to assess the bone density, as this is a cholestatic disease like primary biliary cholangitis, and people do not absorb some of the vitamins, including D, E, K, and A, and assess for these deficiencies. We monitor the biochemical profile, and of course, if we have evidence of dominant strictures, we are having in mind always cholangiocarcinoma. We consider screening these patients every 6 to 12 months for cholangiocarcinoma, as we discussed earlier. And colonoscopy is important for patients with inflammatory bowel disease, as this population might have evidence of dysplasia as well. In patients with significant deterioration in cholangitis, we're not waiting. We proceed with ERCP and try to dilate dominant strictures and sometimes stent these patients. And of course, liver transplantation is an option for patients with advanced disease, and we need to keep an eye. In my experience, primary sclerosing cholangitis has evidence of recurrence actually in the new graft, and we need to keep an eye for recurrence of the disease after liver transplantation. Having said that, I would like to thank you very much for your attention.
I'm a professor and department chair at Baylor College of Medicine in Houston, Texas. It is my pleasure to talk to you today about hepatocellular carcinoma diagnosis and treatment. I don't have anything to disclose. We'll follow a fairly simple outline. I will have a few minutes on the diagnosis of hepatocellular carcinoma. Then the bulk of the talk is going to be about updates related to the management vis-a-vis staging and treatments. And then I'm going to end it with a really important concept of how to manage this tumor, which is multidisciplinary care. I'd like to start by saying that it is now the fastest rising cause of cancer-related deaths in the US. Multiple maps shown between 2003 to 2012. The redder color indicates higher incidence and mortality rate. And as you can see, almost all the states have gone up in the color intensity. And the states that are contemporarily have the highest incidence rates for hepatocellular carcinoma are located on the West Coast and South. And my home state of Texas happens to lead the nation in the incidence of hepatocellular carcinoma. So this talk assumes that this audience knows what the risk factors for hepatocellular carcinoma. And just to give you a quick update here, cirrhosis is the precursor lesion. Most of the practice guidelines indicate or advocate surveillance among those who have cirrhosis for any reason. So assuming you're doing that, you are likely to stumble upon findings that are abnormal in your surveillance test, be it your imaging, which is typically ultrasound, or your biomarker, which is typically an alpha-fetoprotein. So if that ultrasound showed a small lesion, and by a small meaning less than 1 centimeter, most modalities, be it cross-sectional imaging or biopsy, are not really sensitive or specific for verifying such a diagnosis, and therefore most people would advocate repeating the ultrasound in 3 months and watching for changes in the size of the lesion. If the lesion enlarges or it's already larger than 1 centimeter, or you have a biomarker that is elevated greater than 20 nanograms per ml, then the follow-up test is a diagnostic test, which is a dynamic contrast enhanced CT or MRI. If you do that, then there are classical features on cross-sectional imaging, CT or MRI, that should nail the diagnosis of hepatocellular carcinoma. These features are 2. One is the arterial phase. During the, there's an artificial hyperenhancement, meaning the contrast rushes into the tumor, which is hypervascular due to its dual vascularity from portal and hepatic vessels. While the rest of the liver hasn't taken up contrast, you notice the left panel, the arrowhead, points to accumulation of contrast in a tumor that happens to be hepatocellular carcinoma. On your right panel, a 5-minute delayed venous washout finding, meaning in a tumor that is hepatocellular carcinoma, because of the hypervascularity, again, there's a rush out of the contrast out of the tumor while the rest of the liver still has contrast in it. So the combination of arterial phase hyperenhancement and a delayed venous washout in a tumor that is greater than 1 centimeter is classic and diagnostic for hepatocellular carcinoma. But as you may know, life doesn't work in a classic way, and there are many ambiguities and differences in what I just mentioned, which is the size, the arterial enhancement, the delayed washout, the growth over time. And another classic but not so common sign is the enhancing capsule. And depending on the confluence of these criteria, you can end up with something that is really definitive for HCC or something that is less definitive. In order to reduce the ambiguity of reading and reporting cross-sectional imaging for nodules that are suspected for hepatocellular carcinoma, there is this schema, which is the liver diagnostic radiology group. LIRADS or LIRADS is the scheme. And I would advise most of you who deal with this entity is to have your radiology group or department try to subscribe to this nomenclature or something close to it that allows communication in definitive terms. To demystify it, you notice this table. This is the arterial phase hyperenhancement, and the size is less listed here, and the other major features are here. So if you have someone who has everything, arterial hyperenhancement, large size, and the other features, they end up with a LIRAD 4 or 5, and M meaning most likely a tumor in it, probable or definitive. If you have someone who have none of that, a small tumor with no arterial phase hyperenhancement and none of those features, then they end up with the LIRAD 1, which is definitively benign. LIRAD 3 is the most confusing entity because it's mostly not hepatocellular carcinoma, but depending on the studies, anywhere between 20 to 30% may actually have hepatocellular carcinoma, either at the time of the cross-sectional imaging or few months to few years later. So it doesn't help you that much in nailing the diagnosis in L3. And as I will mention, this is a time for exercising your right to do a nodule biopsy. So this will be for your reference, and it's not to be memorized, but it is something to be communicated. And again, L4, L5 is HCC, L1, 2 is not HCC, L3, you're really not sure, but you can't let them go. So the role of biopsy results from the fact that you have a LIRAD 3 where not all the features are present. So on your left side panel here, the most left panel is an arterial phase that shows nothing. There is no enhancement. While on the portal venous phase, there is an actual venous washout. So that's atypical. On your right two panels, there's an arterial phase hyperenhancement, but not much of a delayed venous washout. So that's one indication for a nodule biopsy. Everything I mentioned goes out of the window if we're dealing with someone with liver nodules in the absence of cirrhosis. There, you don't do following up, or you don't do alpha-fetoproteins either. You just go straight for biopsy because the likelihood of metastatic cancer or non-HCCs is high, and you want a definitive diagnosis for that. The practice has shifted where there is a resurgence of more biopsies of nodules done, particularly in the setting where patients would be requiring systemic therapy. Newsflash here, this is going to be really the new part of my talk, is there is now a plethora of new, promising, and even upcoming systemic therapies that are mostly now in the domain of the oncologist, but will require more of these nodule biopsies to happen. So now we're done with the diagnosis. We found a nodule, we suspected it, we moved it across the algorithm, and we got to a diagnosis either by LIRADS 4 or 5 or a nodule biopsy. Now we go to staging. No one should memorize all of those stagings, but if you're a simple person like me, all these stagings depend on 3 broad factors. The tumor characteristics. Is it large? Is it multiple? The liver function. Is it compensated? Is it decompensated? And the person's performance status. Are they holding it together or they have comorbidities? Most of these classification and staging systems utilize one element or more of these three broad things. If you want to be practical, there are probably two staging systems. One is the Barcelona Clinic Liver Cancer, BCLC, and the other is the Hong Kong. And these probably are the most validated systems that are linked to treatments. I'm going to use the BCLC to make a point here of the different treatments that are available. So again, everything starts with a cirrhotic liver, not non-cirrhotic liver. And you have a very early stage. If you have a solitary tumor, less than 2 centimeters, preserved function with great functional status. And in that case, curative therapy could be provided by either ablation or resection. You move to a next stage, which is early stage or A, and that's the Milan criteria that hopefully most of you are familiar with. It's either a single tumor, less than 5 centimeters, 2 to 3 nodules, less than 3 centimeters, preserved function, good functional status. If it's solitary, which is the one tumor then, and they're optimal surgical candidates, then surgical resection is a possibility. If not, then it's a transplant. If there are people who are not liver transplant candidates, and unfortunately there are many who would not get into the transplant candidacy, then they move to ablation and many other things that we're going to talk about. Intermediate stage, admittedly, this is somewhat of a hodgepodge group. It has many people who probably don't have the same disease pathology or prognosis, but they're lumped in this group. And traditionally, chemoembolization has been the group employed here. Then you get to advanced stage, and by advanced stage, it's portal invasion, extrahepatic spread, but still preserved liver function and still decent functional status. And that's where systemic therapy was traditionally being employed. Carrying on the theme of a newsflash, this is an area of expansion, the advanced stage. We're taking more patients possibly from the intermediate stage to the systemic therapy group. So I'm going to touch on the main modalities of treatment. Surgical resection, it achieves best results in patients with BCLC stage 0, offers a long-term survival of 5 years, 50 to 60%, but because you do leave the rest of the liver behind with practically the same disease left behind, the 5-year recurrence-free survival is low, 10 to 20%. This may change as we're getting to cure more hepatitis C patients, but these are the data as of now. It has a small but definite treatment-related mortality, and you can also employ it in some patients beyond the liver transplant criteria. And if you remember from my previous slide, there was an arrow that a singular tumor with a hepatic reserve that is reasonable and a good overall functional status, then resection could be indicated. The thing that is easy and practical for you to remember, that if people start showing clinical size of portal hypertension, probably surgery is contraindicated at that point in time. The poor man's test for portal hypertension or poor woman's test for portal hypertension is probably serum bilirubin. And believe it or not, it's a cutoff of 1, which doesn't take that much to get you a bilirubin more than that to indicate significant portal hypertension. But if you can measure, obviously, the hepatic venous pressure gradient, then it's anything greater than 10 millimeters per mercury. And again, the presence of portal hypertension is likely to constitute a contraindication for surgical resection because the operative and immediate post-operative mortality increases in the presence of portal hypertension. Liver transplant, you need to remember the Milan criteria. They're shown here on the slide. If you transplant people with these criteria, the 5-year survival should be greater than 70%. The recurrence rate should be less than 15%. Alpha-fetoprotein on top of the Milan criteria gives you an additional prognostic factor, a bad one, I should add, greater than 1,000, predicts 50% recurrence. And a big problem in liver transplant, well, there are multiple problems. One of them is there aren't enough livers to go around, and HCC competes with many other illnesses. The second one is, and it's a product of the first one, is people who are eligible for liver transplant and get listed to receive a liver transplant drop out of the list if they have HCC due to HCC progression. So nowadays there is the downstaging for HCC and the bridging for HCC. Basically, taking someone who does not qualify for liver transplant based on size and nodule number criteria, giving them ablative therapy or transarterial chemoembolization and bringing them down to liver transplant criteria and allowing them to be listed. Another utility of such treatment is while people are on the list, if they grow, you try to downstage them and bring them back to the list. The beauty about this, if you will, maybe beauty is not a word I should use here, but the usefulness of this technique is, A, if you bring them down to a stage that is still Milan, they do get exception points. And I intentionally didn't show the number of points given for which condition, because these things tend to change. But the concept is, for people with documented HCC on a transplant list, they get few exception points that pushes them up the list. So if you do downstaging, you still get those points. The second one, it's a time buying maneuver. In other words, if you downstage a patient and they remain downstaged for a long time, you're probably selecting those who are going to do better with transplant and transplanting them with, in a way, double secure favorable outcomes. So this is to summarize and to put a plug in for my last point of the talk, which is going to come later, the multidisciplinary thing. So despite my boxes and despite the arrows and despite showing it somewhat relatively clean in terms of decision making, it's not that clean. So if you have people with, and here I'm shifting classifications on you, a TNM, T1 is 2 centimeters or less or greater than 2 centimeters with no vascular involvement. T2 is slightly larger, but basically it's a Barcelona stage, early or very early. And you stack up the 3 possible treatments here: liver transplant, surgical resection, local ablation. It's a very tough comparison. Look at the 5-year survival. Yes, liver transplant is slightly higher. The other 2 are not very far behind. The recurrence-free survival is a problem for the other 2. The procedure mortality is a real problem for the liver transplant, and availability is an issue for liver transplant. So once you eliminate the possibility of a liver transplant, you do end up weighing, which one do I do, surgical resection or local ablation? And it seems like the preponderance of evidence, which is not fantastic, by the way, favors resection over radiofrequency ablation, but it is something that people debate every day. And the debate is the issue I want to leave you with. You need to have a multidisciplinary tumor board or a group that discusses those things, because these decision points are not clear. There isn't that fantastic randomized control evidence that you can hang your hat on every time. And it's a matter of debate and almost negotiations on who does which procedure better in your particular setting. So now I'm going to move to local regional therapies. I'm not going to discuss these in details, but cryoablation, which is obviously cold, radiofrequency ablation, which is the classic way of local ablation, microwave, which is overtaking radiofrequency ablations in some places because it can ablate more in one setting. Then you have stereotactic body radiotherapy, yttrium-90, which is radio embolization, and transarterial chemoembolization. I will just put one slide on radiofrequency ablation. As you can see, a probe is inserted, gets closer to the tumor, then the spikes of the probe are spread, and then you put the current and you basically heat it. It's highly efficient for ablating tumors less than 3, possibly less than 4 centimeters in diameter, complete response in 55%, particularly if they're less than 3 centimeters. And the predictors of poor response, well, you already guessed it: size, infiltration, poor differentiation. It is contraindicated in some anatomic related reasons, located at the dome, next to the gallbladder, next to blood vessels, in the caudate lobe. So there are some instances where the operators say, I just can't do it in this location. Severe complications are relatively infrequent, 1 to 10%. Mortality is quite low. Tumor dissemination, while described in the earlier studies, it's probably really, really low. You just bear in mind that you probably want to avoid it if transplant is an option. And microwave ablation, that's MWA, is the one that is now being used. The arterial-directed therapies, transarterial embolization is basically bland embolization, not very frequently used. Conventional TACE, it has the strongest evidence of benefit from randomized controlled trials. The problem is systemic release of chemotherapy plus the usual post-embolization syndrome. Therefore, drug-eluting bead TACE, which comes at a greater expense but slower release and directed release, and therefore less systemic therapy, less systemic toxicity is an option. And finally, radio embolization using yttrium-90 is more expensive, but it has its niche use in instances particularly where there is portal vein thrombosis, where it's not safe or even possible to do transarterial chemoembolization. It may improve time to progression. You need fewer sessions. Not every place offers it. It's a more specialized procedure. And there is a dearth of randomized controlled trials comparing these modalities to each other. And therefore, you still need your tumor board. So now I'm going to shift to systemic therapy. And this is a slide that sort of updates my earlier slide about the Barcelona classification and the choice of treatments. Basically shows in that intermediate stage, in the old days, you consider TACE, you keep TACing them, and if they don't respond, there's really not much you can do. In this case, I think there's more push or more recommendations for taking some of the cases here that fail their initial TACE or perhaps a repetitive TACE and moving them into the more advanced stage and considering systemic therapy. So what's happening in systemic therapy? This was the slide that we would present in 2007. There was one treatment only, which is sorafenib. Things have changed, and I'll show you how this table gets populated. So first change happened when lenvatinib, another tyrosine kinase inhibitor, works similar to sorafenib, working on different PKs, showed non-inferiority to sorafenib. Showing this slide, which shows the median progression-free survival, lenvatinib actually had slightly better median progression survival, although in the same study, overall survival was not different. But this study and non-inferiority led to the approval of lenvatinib. So we ended up with 2 targeted therapies for first-line treatment. Then came a slew of second-line treatments: regorafenib, cabozantinib, and ramucirumab. And I will describe them briefly. Regorafenib, remember, all of these studies are second line. So they enroll patients who already failed sorafenib. They randomize those patients to the active, which is in this case regorafenib, or placebo. The results are shown comparing those two. The red is regorafenib. The higher, the better. The top graph is overall survival. The lower panel is progression-free survival. Different endpoints. Don't need to be a statistician to figure out that the red is higher than the blue in both. You probably need to be a statistician to read the small font of the hazard ratio, 0.63 significant and 0.46 significant, meaning regorafenib offers 2 to 3 months survival advantage over placebo among those who failed sorafenib treatment, and that gave it the indication of being a second-line therapy. Cabozantinib, again after sorafenib failure, same study design, same results. Red is cabo, blue is placebo, 2-month advantage compared to placebo in those who failed sorafenib. Before I present the last of the second therapies, which is an immunotherapy, the rationale for immunotherapy is quite attractive. HCC is an inflammation-induced tumor, at least the viral hepatitis ones. Spontaneous immune responses have been observed, activity is not dependent, activity of the medication that, or the metabolism of immune therapy is not dependent on liver function. So that's an advantage in people who have cirrhosis. And you can combine it with other therapies, both locally and systemic. So a second-line therapy is ramucirumab. And again, the same design, HCC documented progression of disease or intolerance on sorafenib gets randomized to ramucirumab or placebo, and the results are advantage to ramo versus placebo, and the difference is 1 to 2 months. So I've reviewed 3 second-line therapies. The table is filling more, and this is the most exciting thing of my talk, and hopefully it's new for some of you at least. Beva Atizo, bevacizumab, and atezolizumab, and I'm going to call them Beva Atizo for obvious reasons. So a big study, MBRAVE or IMBRAVE 150. Those are patients who are locally advanced or unresectable HCC, didn't receive systemic therapy before that. An international study stratified them by regions, stratify them by their functional status, macrovascular invasion, and baseline alpha-fetoprotein. Randomize them to the combination of atezo, beva versus sorafenib. This is a head-to-head against sorafenib. Followed them for overall survival and recurrence-free or progression-free survival. Those were co-primary endpoints, and these are the results. I maintained the red for the sorafenib, but now the blue is the combination. And look at the 6 months overall survival, 85% compared to 72% sorafenib, clearly longer, clearly better, statistically significant. Benefit extends throughout the follow-up up to 1 year and even longer. If you look at progression-free survival, look at, again, the 6 months, a benefit of approximately 20%, 55% versus 37%, and again, statistically significant. If you look at the safety, the notorious safety issues related to sorafenib, where the rashes, which are not present in the atezo-beva. Most of the adverse events that happen greater than 10%, and there's difference, are on the side of sorafenib. So diarrhea is more common, the rash is more common, decreased appetite is slightly more common, hypertension is slightly more common in the combinations, abdominal pain more common in sorafenib, alopecia, asthenia, fatigue. I mean, that's a major issue with sorafenib. So if you're wondering about quality of life, it seems that quality of life, which is important for people with this disease, is better with atezo-bev. So the landscape has changed. In 2020, beva-atezo have displaced sorafenib or lenvatinib as first-line therapy. And so that's your first-line therapy for virgin, naive patients. Those who are already on sorafenib or lenvatinib, if they fail it, then immunotherapy becomes a second-line therapy or targeted therapy. For the first-line beva-atezo, if they fail it, possibly your tyrosine kinase, which is sorafenib, lenvatinib, or some of the other things that I mentioned for second-line therapy. Admittedly, apart from this box, which is this is your first-line therapy, there's very little to guide us in terms of clinical trials on what to do next, but it's an exciting area for investigation and certainly a reasonably good time for those unfortunate patients with hepatocellular carcinoma. So I want to summarize the front line and mention 2 things about the multidisciplinary approach and then wrap it up. So bev-atezo is superior to sorafenib in all these measures, and it's consistent across the HCC groups, should be widely adopted as a standard frontline, and there are multiple additional frontline combinations that are coming in phase 3 studies, and they're listed on this slide. So I mentioned several points where just the status of the knowledge and the experience is not sufficient for any one person to make a judgment on what is best. And the result of this confusion is curative treatment is underused among patients with early stage HCC. Therapeutic delays are significant and frequent. Even today, multidisciplinary care, and that has been shown, not just me saying, improves stage at diagnosis and treatment receipt, and is even associated with longer survival. How do you do it? Multiple ways. One of them is what everyone aspires to do, a single-day multidisciplinary clinic and conference. It's wonderful, very difficult to put together all the subspecialties, seeing some patients on the same day, but if you do it, great for you. Single-day multidisciplinary clinic and conference. So what I just mentioned is the clinic, but sometimes it doesn't have to be a clinic all in the same day. You can have them and then schedule a conference. Or you can have a fluid referral, have them see the different specialists, and have a quarterback puts it together. In our institution, that's what happens most of the time. All of these things listed the studies: improved early detection, utilization of curative treatment, time to treatment, and survival. Importantly, there's a real change of staging. People come to you with stage X and end up with stage Z, which means the treatment would have been the wrong treatment if you didn't subject them to this multidisciplinary approach. This is my last slide. A lot was there, but the treatment landscape is changing rapidly. There are curative treatments. If you're a hepatologist, gastroenterologist, your job is to do surveillance, early diagnosis, nail those who will need liver transplant and resection, and figure out who will need palliative treatment by hooking them up to a multidisciplinary clinic or multidisciplinary platform. The systemic therapy through Bev-Atezo has changed. It's a new standard of care. And while things are still being treated with a one-size-fits-all approach, this is a plea for you being slightly more generous with doing biopsies from nodules, because biomarkers are or is the future to determine which patients responds to which therapy. Thank you and good luck.
Can you hear us? Can you unmute? Okay, he's trying to say we need to unmute.
Yes, I can't do it myself. The host has to do it. Hello, everyone. And I would have loved to be with you, but I'm only 4 hours south in Houston.
No problem. You are just a screen away from us.
All right.
So excellent presentation. There are a couple of questions. And one of them is, there are some observations now that people with NASH develop HCC even in a non-cirrhotic liver. So what's your take?
So first, it is true. It used to be possibly a myth, a rare event, maybe 10, 15 years ago. The estimates are, out of those who develop HCC in a setting of NAFLD or NASH, approximately a quarter to a third happens in those without overt cirrhosis. Now, many of them would have some element of fibrosis, but yes, it happens. So why is this important? And hence your question. Because we based our whole algorithm for prevention and surveillance based on recognition of cirrhosis as the essential lesion. So if there is a 1/3 that is going to bypass that pathway in a condition that affects a quarter of the adult population, then potentially we have a big problem. So my point number one, yes, it happens. Point number two, how can you identify them? I'm sorry, that is still very difficult. The best I can say is those who have multiple metabolic risk factors, so they have diabetes, hypertension, obesity, and they're getting older, they're probably the ones who are more likely to bypass this pathway. Point number three is it is not cost effective to do surveillance with any modality among the masses of NAFLD and NASH in order to identify that. So for now, high index of suspicion and detect fibrosis and stage it early.
Thank you. Are you using L3 for patients?
So we are using it in a research protocol so far. We have not moved to using it in clinical practice. I think I will be tempted to use the combo, the triple biomarkers, that is, in a context of a GALAD score. That would be the closest that I could recommend that, because it does offer a small incremental benefit over AFP alone.
So another question is that there is a prolongation of the survival rate with different compounds, TKIs or IO. But the question is this cure?
No. So this is an important point. These are all palliative treatments. There are some, freak accidents of people really responding to something to a degree that close is to cure. But these are essentially effective palliative treatment. Now, I don't want people to poo-poo this, because until recently, we don't have anything that is effective palliative treatment. So they do prolong life by few months, and few months are not too trivial in this entity. Second, they could spare people from multiple ablative therapy that may or may not be effective and is associated with a lot of impairment of quality of life. Third, the future is combining these therapies with other modalities that I believe the combo is going to be a mainstay of therapy. Fourth and last of all is most cancers are managed like this, and you hope for effective palliation, but not cancer. But the future is relatively brighter than it used to be just a few years ago.
Excellent. There is another question that is in regards to gallbladder polyps, if I understand very well, in asymptomatic patients. Are we doing cholecystectomy or we're following them?
Wow, so, although that wasn't my talk, I think I can answer this. So I think the cutoffs nowadays is 1 centimeter for prophylactic cholecystectomy. The indication to screen for gallstones is one of those indications in primary sclerosing cholangitis, where the odds of developing gallbladder cancer, even in asymptomatic small stones, is there. So if there is a polyp or a stone or something that is small, then observation is recommended. If it enlarges over time, then cholecystectomy is indicated.
And the final question is, what's the role of alpha-fetoprotein in overall medical care of HCC?
In which one again?
Role of alpha-fetoprotein in overall medical care of the HCC patient.
So the role is several. First, it is considered to be a surveillance/diagnostic. High titers of alpha-fetoprotein or high levels are poor indicators of survival, even among those who get transplanted with Milan criteria. Downstaging and bringing alpha-fetoprotein to 500 or less and keeping it low like this for a year or so buys you melt points. Despite a lot of lukewarm feelings about AFP as a biomarker for detection, it actually has a lot more utility in the management of the cancer. And as our moderator can testify, as he's a transplant guy, people do use it in transplant indicators and engagement of therapy.
Unequivocally, if the alpha-fetoprotein is more than 1,000 during the evaluation, we need to downstage the patient and bring it down to less than 500. Alpha-fetoprotein more than 400 in the transplant setting has been associated with lymphovascular invasion. And this is the #1 danger for people to develop recurrence of the disease. And having said that, Hashem, it's a pleasure. Thank you so much. Hopefully
Thank you very
we'll be
much.
able to see you next time.
Thank you all.
Come back to New Jersey. You have
all
a
right.
training over here. And I would like to invite Dr. Rasky, please.
Well, I think we've had a day and a half of very, very good lectures. Hopefully you've all gained some information you can use come Monday or whenever you return to work. I do want to take this opportunity to add the thanks to the Focus Med people as well as our sponsors. For your CME, final reminder to please go to livegala.org and fill out your post-meeting questionnaire so you can get those credits and ABIM mock points. So enjoy the evening, enjoy the rest of the weekend if you're here or anywhere else, and thank you very much for attending both in person and virtual. Thank you.